Sunita Agarwal. I'll give a small introduction of her. She is MD, FSCP, FRCP, FICP, FIACM, and she is a director professor at MAMC Delhi, in charge of Hematology Clinic, HDCC, LNH Delhi. And she has done some oration at Dr. G.S. Sainani by Association of Physicians of India, Srimati Pawan Kumari Jain, Delhi. She is the principal investigator in multicentric international clinical trials, and she has various publications. Dr. Sunita?
I'd like to thank HFI for inviting me on World Hemophilia Day for such an important topic, that is women and girls with bleeding disorder. The managing women and girls with bleeding disorder. First of all, I would like to highlight why this topic is important to me. Because these women and girls with bleeding disorder usually present with the menstrual bleed. This is a gynecological problem, and this is usually missed a lot. It initially during the menarche, it is always a perceived. Initially, first 2 to 3 years, there are always heavy periods. Usually, physician and gynec really don't bother about it. So I would say it is under recognized. Don't recognize, you will not proceed for the diagnosis, and you will not even send the investigation, that is left undiagnosed. And then no treatment, no specific treatment. They are getting the symptomatic management like the blood transfusion if needed, and iron infusion, and the some oral tablets, but not specific investigations, not specific management. So three words for these girls are under recognized, undiagnosed, and suboptimal treatment. This is the dilemma faced by these girls. They are not usually uh, taken seriously during the initial menarche period because of the poor awareness, even among the healthcare workers. Even when the patient comes in our OPD, in medicine OPD, we usually refer to the gynae OPD. In the gynae OPD, they do some pelvic exam, ultrasound pelvis, and some basic investigation, or it is usually not given a thought that we should investigate these patients for inherited blood disorders. So always delay in the diagnosis, and the delay in the referral, and the specialized testing, even the lack of specialized laboratory. Even in hemophilia treatment center, there is lack of female care pathway. Usually thinking this, yes, hemophilia is a male disease, it is not a female disease. And then in clinical trials, he would say that in hemophilia, most of are the males, not even a single female. And there is a knowledge gap in the suboptimal treatment. Even at present, there is no consensus regarding the clear-cut guidelines, neither by the American Society, neither by the European Society, regarding the treatment of these patients. These are either it can be the primary hemostatic disorder or the secondary hemostatic disorder. I will not go into the detail, but I would say von Willebrand disease is the most common disorder in the WGBD. This definition is already covered by the two speakers: hemophilia carrier, symptomatic, asymptomatic, mild hemophilic female, moderate hemophilic female, and the severe hemophilic female. Remember, it is not uncommon. It is usually thought that females they are not hemophilic. I am doing a thesis. Data is to be collected maybe in the last month of this year. I have screened 40 carriers females. Out of these, I found 5 females have less than 40%, and they don't have any symptoms. I just focus on the male child and their mother and their sisters. Then I able to find out of 45 having the factor level less than 40%. These are the already discussed signs and symptoms of the bleeding disorder in women and girls. In childhood, mainly the nosebleed, bruise, excessive bleed. In adolescence, of course, menorrhagia, heavy menstrual bleed, and the pain during the ovulation period. It is usually missed because there is an hemorrhage in the egg. Then the in adulthood pregnancy problem, already a beautiful lecture delivered in the morning, as well in the postpartum hemorrhage, even in the late childhood, mainly the surgical problems, because these are old age, maybe the elective surgeries, ophthalmic surgeries, orthopedic surgery, they are diagnosed. Obstetrical complication is already highlighted very beautifully. Remember, whenever you see a patient of the high menstrual bleed, if you work up 5 to 10%, seek medical attention only. Rest left undiagnosed. Out of this 5 to 10%, 15% may have the inherited bleeding disorder. But over literature showed the average time spent when the onset of the bleeding and the diagnosis of a bleeding disorder is maybe few years to 16 years. Means it has already crossed the adolescence. What do they? These are not only the bleeding which is bothering them. It is a major impact on the quality of life. How? Whenever you have bleeding during the menarche, heavy menstrual bleeding, too early change of pads, very poor quality, usually don't attend the school, poor academic performance, anemia, iron deficiency, frequent hospitalization, difficulty in marriage due to the heavy menstrual bleeding, then conception problem, delivery problem, postpartum, difficulty in taking care of child. All these affect the quality of the life. So this topic is very sensitive and you have to focus on WGBD. Then what are the basically key factors when you suspect these patients? Yes, we have to investigate. If the patient has the multiple bleeding problems, sometime from nose, sometime from the mucous bleeding, and this is the menstrual period, recurrent ovulation bleeding, patient in the mid cycle say ki I have the pain in the abdomen, family history of the bleeding symptom, mother having the recurrent bruises, recurrent ecchymosis, iron deficiency with no, just due to the heavy menstrual bleeding, and the history of primary and the postpartum not associated with any gynecosis. When you suspect, then you refer. Refer to a highly specialized laboratory, but initial investigation you can perform easily. You can at least do the CBC, you can do the bleeding time, you can go for the clotting time, you can go for the PT and APTT, then refer the patient for the specific investigation. Then how will you manage these patients? Remember, these patients need the personalized treatment. Every patient is unique in their symptoms, in their bleeding phenotypes, in their severity, even in the clinical circumstances. There is a big challenge because there is a significant difference in the clinical practice even among the healthcare providers and the lack of evidence-based guidelines. They need comprehensive care, multidisciplinary clinic, which involve both OBS, physician, nurses, and blood transfusion care. Even they need the preconception counseling and genetic counseling. We have already discussed how to suspect. This is the chart which is made by the European Society, because when patient will not tell you what is the heavy menstrual bleeding, you have to give them some chart so that they can write. If it is more than 100 Phillips tool, you can go for it. Or most easy is this is the BAT score. This is the self-assessment tool. If you raise the awareness regarding this tool, these girls will come to you for the diagnosis. We have already discussed this. When you do the code testing, green dot is the factor level confirmation, but every time factor level estimation is very costly. It is real expensive. So we cannot go for every time during the puberty, young adult, pregnancy, delivery. You have to prioritize when to do it. Whenever there is a bleeding, you can go for, depending upon the factor level. If it is a mild hemophilic, then you go for the antifibrinolytic therapy. If it is moderate or severe hemophilic, then you can plan for the clotting factor deficiency depending upon diagnosis, whether hemophilia A, hemophilia B, factor 13, factor 10th deficiency. Like that, if it is a platelet disorder, you can plan for the platelet. These are the guidelines and the treatment side effects: tranexamic acid, desmopressin, recombinant. Even if only patients suffering from the heavy menstrual bleeding, you can plan for the hormonal therapy, estrogen and progesterone. This is the treatment guidelines already discussed. What is the standard? Mainly mild hemophilia, more than 30%, they can be easily managed with the tranexamic acid and desmopressin. But if it is a moderate or severe hemophilia carrier, you have to give the factor concentrate, maybe doses in the 20 to 50 unit per kg depending upon the severity and the site of bleed. This is if they want to continue the pregnancy and they want to have plan their family, then you can plan the different surgical option if they have completed their family. These are the only pharmacological therapy. It is not enough for these patients because they are going under the stigma, taboos lot, and they are usually don't come forward. So in our hemophilia treatment center, there should be some psychosocial support team for these patients. At least they can talk to them. They can basically calm down. It is normal or it can be treated. So they need counseling at the time of menarche, at the time of adolescence, at the time of marriage, during their sexual life, during their preconception, during pregnancy, even after delivery, and for the neonates. And of course, they are suffering from the lot of psychological problem. My thesis is going on the depression in hemophilia carrier. I am using this DAS score, and this is showing that these patients are suffering from mild to moderate depression, but results are to be compiled in last month of this year. Now, what is this health promotion? This is a pharmacological treatment. When you diagnose the patient coming to you, then you can offer the treatment. What about to diagnose which are the still undiagnosed? Then the health promotion, that is the awareness activity. That the CDC along with the National Hemophilia Foundation in United States, they carry out the various promotion and the preventing program. The desired outcome, women and girls to recognize their bleeding symptoms, to identify with the sign and symptom of the bleeding disorder, send them for the diagnostic testing, appropriate diagnosis and appropriate treatment, so that complication can be prevented. There is the various basically tags or hash lines are there. Let's talk period, Irish no UNUFO, better you know, is the basically it is a tool basically where they can fill their data ki how much they bleed, and they can assess whether they have suffering from the heavy menstrual bleed or not. Then this is a Facebook group, and there is the Insta group in which they discuss with their fellow patron, and so that they are able to discuss so many things ki it creates a relief in them ki yes, we are normal or we can proceed for further treatment. Even the discussion group among these groups are taken, they share their experiences, share their taboos, share their stigmas, share their pregnancy, reproductive health, and it creates a lot of bonding between these people, and they take care of each other. Even they have developed the online learning management tools in which they increase the knowledge and the awareness and the future activities to train the healthcare worker. This is done by CDC in collaboration with National Hemophilia Association in United States. With this program, they have published the data in 2024 in Journal of Women Health. Number of the female with bleeding disorder rose by 47.3% over a 9 period. Initially, it was 6169 in 2012. Now it is 9088. Additionally, patients receiving care treatment for bleeding disorder increased by 17%, 28.8 to 33.6. Just it is a awareness activity. They come forward, they discuss, and then they go to treatment. They go for the treatment. So in the last slide, I would say women and girls with bleeding disorder deserves better care, more understanding, faster diagnosis, time to break taboo, ensure that symptoms are taken seriously. No woman should have to suffer in silence, and their health should not depend on ignorance and stigma. That's the theme of World Hemophilia Day, Women and Girls Bleed Too. That is the theme of Indian Hemophilia Society today. That is the commendable dose to highlight and to raise awareness regarding this women and girls with bleeding disorder, so that we can treat these patients, not only males but females also bleed. Thank you very much.
lot of stigma exists about menstruation in females, among females themselves, because they believe whatever is going is all bad blood, and especially in the rural areas. So if they have excessive bleeding, they think all the bad blood is going on. This is one thing we have to educate them. Second is isolation of people under menstruation. These people are kept isolated, not given enough food, till they are not allowed to touch anything, including flowers, plants, everything. Few days back, 2-3 days back, there was a newspaper report. A girl who had attained menarche. She had come for exams. She was studying 8th standard. She was made in the school. She was made to sit alone on the steps with the exam. There's a big hullabaloo about it, and somebody had taken a video, and then it had been published and all that. So still, it is for us to educate them, so that awareness about menstrual disorders, even among our own carriers, they don't come out with how many days of period they have. They say, we are normal, we are normal. On further inquiry, we find most of them have bleeding beyond days. So, even for us, in the Hemophilia Society, we have to also take care of the carriers. This is important. Thank you. Even here, there is a distinction. I will not tell you about this seminar has got a different setup, and yesterday's was in a different setup. I won't bring out what that is. I will talk to whoever is the authorities. Thank you.
Thank you, Dr. Nalini. Thank you, Dr. Sunita Agarwal ji. That was wonderful presentation which covered everything that we wanted to know about. I would like to call Sunita and Kalpana to felicitate them. Radha Krishnan. She is additional professor and head Department of Pediatric Hematology Oncology, Postgraduate Institute of Child Health, Noida. His professional responsibilities are chair, Childhood Cancer Working Group, International Pediatric Association member, International Society of Pediatric Oncology and Asia Board Nodal Officer, Hemophilia Thalassemia Service, GB Nagar member, and many other things. So, Indraman.
To all of you, congratulations to HFI for this meeting today. Quite a few topics which have overlapped, so I'll try to stick to things which we have not discussed till now and skip over the rest since we are already running a little late. I've been asked to speak on awareness generation, access to diagnostics and access to care in von Willebrand disease and other bleeding disorders. So that's what we'll see in the next few slides. So this is the annual global survey of WFH, which 2023 is published. Data comes from national medical organizations. India's NMO is HFI, and this is the data that has come in, which shows that there are close to, when you have close to 2 lakh patients with people with hemophilia living, we have around 1 lakh von Willebrand disease that have been registered globally and 70,000 other bleeding disorders. In India, this is a little older data. I have recent data from HFI coming up. So this is HFI's data from 2025, which shows von Willebrand disease to around just about 1,056 people with VWD in the country currently, and you can see the rest of the bleeding disorders as well. Globally, as well as in India, I am presuming that the diagnostics has improved. Globally, there has been a real improvement which can be documented from say 2000 to 2023. In India, this data with the earlier slide was last year's, that is to 1000 odd BWD and 1056. So I don't think there's been a real improvement in terms of diagnostics. Diagnostics is still limited to centers, very few centers which can do it, and that is probably one of the biggest challenges that we face in terms of BWD detection. This is the good thing is that globally everyone's focusing on women and girls with bleeding disorders. So this is the data which has come from 109 countries, and this is the AGS 23 again. So here you can see patients who are the number of female patients you can see, and even BWD by sex if you see 55% are female, 33% are male. This is the distribution of other bleeding disorders in the AGS. Now, like we discussed, like has been discussed so far, if you look at women with inherited bleeding disorders, it could be any of these 4 conditions, and this is what we are seeing. So, like we said, till now there is a lot of issues. I'll take off from where Nalini ma'am left off, saying that there's so much of things that is stigmatized regarding diagnosis. We'll just share a work also which was done primarily with HFI a couple of years ago. So it's a no man's zone as far as a woman with bleeding is concerned. Nobody really wants to take the onus of it. There is delay in reporting to a doctor because the family does not bring the child to a doctor. Many a times it's after hemoglobin drops to like 3 or 2 and the child is almost about to die. That's when we get to see the child for the first time. Even if you get to a doctor, like was mentioned earlier, it goes to the gynecologist. Gynecologist will give treatment saying that it is DUB, dysfunctional uterine bleeding, and it never gets to a hematology service. And even when you get to a hematology service, to get to a correct diagnosis becomes a challenge. That's the investigations and all those investigations needed in BWD are available only, and I don't think it's available in all centers, in all the tertiary centers also. It's very few centers that can do it. And finally, to get a multidisciplinary care, to get a gynecologist, an obstetrician, with all the other specialties needed for hemophilia care, that would be required for these women as well, so that becomes a challenge. So, this is the bleeding profile, and again it's not just they have menstrual bleeds only, they have a lot of other bleeds as well. So it is menstrual bleeds, and there is something called mid-cycle bleeds because of ruptured corpus luteum. So that again is an issue in these girls. So it's not in between cycles they have spotting, and sometimes that can be really bad. It can cause hemoperitoneum shock as well also. So quite a few VWD kids come with that, and the good thing is all this gets treatable. You can be very well controlled on oral contraceptives with Tranexa and some little bit of factor support, but you just have to recognize and tell them that they have to be compliant to the treatment properly. So during menstrual cycle, it's just not the menstrual bleed, it could be in between as well. So among women who come with uterine bleed, so this is the delay that you can see. Like even if 80% of VWD women have heavy menstrual bleeding as a presentation, out of women you see, if you have picked up those who had heavy menstrual bleeding and then evaluate them ahead for inherited bleeding disorders, that is a very small percentage that they pick up. These scores again have been shown earlier. What we usually follow is the ISTH score, and there are a lot of online communities now which help us diagnose. Von Willebrand disease is supposed to be the most common inherited bleeding disorder, but the most common ones are the milder ones. So there will be women walking around with a lot of bruising or a little bit of menorrhagia. They will think that is normal for their family. They never get to a hospital. But the ones which we diagnose and register, they are usually type 3, because that's only when they start bleeding very badly that they come to a hospital, or they have other bleeding symptoms like joint symptoms, etc. Then they get picked up. So this is the ISTH BAT score that we've been using. And as communities, so I think what we need to, one takeaway from today's meeting should be that since this is the topic, let's all have local meetings in our centers. Let's bring in gynecologists to our meetings, and let's talk about what is heavy menstrual bleeding and what requires evaluation. So I think this, if we can achieve in this year, by next year our diagnostic numbers of children who are diagnosed would increase very well, and a lot of public awareness, probably in print media or social media, would also help women report, like not get stigmatized by the fact that they are bleeding heavily. but they report and then they tell us. So a lot of women, so I think I've shared this earlier also, although I do only pediatric practice, one of the patients I was involved in is a 70-year-old lady who underwent a laparoscopic surgery, and after the laparoscopic surgery she was found to be bleeding from the abdominal ports where the scope was put, and at that point she was evaluated and she was picked up to have a picked up to have a raised APTT. And then when you go back and ask the history, she has had menorrhagia throughout her reproductive period, and she has had postpartum hemorrhage, all of that treated with transfusions and plasma, etc. Nobody really bothered to evaluate. So the first diagnosis can be very, very late in our country as well. So this is how the bleeding symptoms are. So what are the red flags in the menstrual part of it? So if you have a menarche onset menorrhagia, so this is again one thing that we should sensitize our families also. We should sensitize our gynecologist colleagues also. As in, if usual menorrhagia that happens in women happens a little later. So it's called dysfunctional uterine bleeding. But if it's a girl who is from the first period at say 12 or 13 years of age, she is starting to have heavy periods. Maybe the first 1 or 2 cycles may not bleed. It's because it's anyway an ovulatory. But after that, when they start bleeding, it's very heavy bleeds. So that has to be a red flag. If there is menorrhagia, the gynecologist has put on some hormonal treatment, it's not really improving, then again it's a red flag. Hemorrhagic ovarian cyst is a red flag. Delayed postpartum hemorrhage. We discharge our women after delivery, they go home by day 2, day 3. But if they are coming back like the second week of delivery or third week of delivery with postpartum hemorrhage, that is again a big red flag, because madam showed that in the postpartum period the von Willebrand factor will be there for a 7 to 10 days. But then once the levels come down, that physiological increase comes down, that is when they will start bleed. So delayed bleeds can also happen. So that should be important. If they have menorrhagia with say gum bleeding or menorrhagia with bruising, again a red flag that there should be looked for an inherited issues. Family history of bleeding. If they have been prescribed iron, if they have received transfusions, that also should be added to this. So this is again, I'm skipping this because it's all been measured. How do you measure, that also has been seen. How do you manage also has been seen. Now, what is the awareness in the community? So this is work which has been done in UK, where they looked at gynecologists, and they surveyed gynecologists and said, they found out that even just 4% of gynecologists actually thought that one of the causes of menorrhagia could be von Willebrand disease. So we've had people who have completed their whole career in obstetrics and gynecology but never picked up an VWD, just because the awareness is not there, and probably when they bleed heavily they would transfuse or they would do plasma, or nowadays even postpartum hemorrhage, recombinant 7 is a treatment which is offered in that as well. So these are issues. So this is one of the earlier work that we had done, called a multi-center kind of a survey with HFI as very much part of it, and we looked at women who bled. So I think there are people in this room who would have responded to this also. So these women were either the people who responded were either VWD, RBD as well as hemophilia carriers, and the age of diagnosis range you can see from 0.8 to 70 years. That was the age range in which they got the first diagnosis. People reported a median time to diagnosis of up to 20 years from symptom onset. Number of doctors whom they had shown before they got to a diagnosis ranged from 2 to 20, and the first diagnosis was a wrong diagnosis in around 70% of the people. And why? How did the bleeding, their daily bleeding, impact their living? They had restrictions at home, they had restrictions for meeting socially, they had restrictions for outdoor activities, they were not able to go to school, or they were missing college frequently in around 45%, and they had financial constraints in 58%. And when we asked them what was the reason for the delay in diagnosis, it was essentially all of these above, as in delay in a medical facility, stigma of approaching a medical facility for menorrhagia, delayed referral to a specialist, delay in getting investigations in the same city because you had to travel to another city, etc. And almost 80% quoted that there were more than 2 reasons why they were distinct. So this is the 2016 HFI Women's Group photograph. So I'll summarize by saying these are the 3 groups of conditions that we have, and here if we focus on von Willebrand disease, awareness generation has to come from sensitizing obstetricians and gynecologists, sensitizing pediatricians, because pediatricians see till 18 years. So to 12 to 18, that adolescent age group is still under a pediatrician's care. So if pediatricians are sensitized to pick up bleeding and not just refer them to a gynecologist, but do some evaluation on their own, that would help improve diagnostics very well. And access to care definitely is an issue, but with through NHM now there is support for VWF as well. So just have to connect them to the right center for diagnostics and the right center for treatment. And in rare bleeding disorders, again, there are conditions which would have a basic screening normal, like factor 13 and platelet function disorders. So if somebody is bleeding significantly, a bad score is positive, if there's a family history, definitely get them to a tertiary center to get a proper diagnostics. There would be genotype, phenotype variability also in certain conditions. The levels may not match the bleeding phenotype. So that all has to be sent. That cannot be decentralized. That has to be centralized in a facility which has the expertise in diagnosing it. Once that is done, definitely treatment can be decentralized with whatever our access we have now. So I'll stop here and I thank you for your patient listening.
Thank you, Dr. Neeta. I would like to call Devrupa to felicitate her. It was a wonderful presentation which covered everything. Yeah, Dr. Nalini, please.
Disorders like factor 10, the females are not so symptomatic any time during their period, but after pregnancy, during cesarean, they bleed a lot. They are found to be major factor deficiency. I've had one patient, she was from Bombay, counseling. I believe she was, her periods were normal and all that, she was going to work and all that. Then when she had a pregnancy in a private hospital, cesarean was done, excessive bleeding, and she had PPH, the child also died. She wanted to have a second child, she was factor 7 deficiency. What do I do? So I don't understand, a simple APTT is not being done even for major surgeries. That is what I find. Other major surgeries, they do a whole lot of investigations, but an APTT is missing. This is my observation. It was a very good seminar, well conducted. Congratulations to all the all the doctors who spoke on this.
Thank you, Dr. Nalini. Dr. Alok Srivastava.
Thank you, Indra ma'am. Those were all very informative presentations, and I'm sure the audience got to learn a lot. The next session we have is on recent advances and treatment guidelines. And the first talk is going to be delivered by Dr. Alok Srivastava, who frankly does not need any sort of introduction. And the talk is going to be on recent advances, gene therapy in hemophilia.
Morning, everybody. About 15 years ago, we started talking about prophylaxis. Before that, for 15 years, we had talked about bringing treatment. It was uncommon to think about prophylaxis at that time. We have moved a long way, and prophylaxis is now a reality, and at least, we've reached a situation where we have more funds available than products to treat our patients. So, it's a good problem to have, but in the same vein, we want to move on further now and say, let's look at cure. And gene therapy for hemophilia has been discussed for a long time. These are not pictures we want to see ever again. And thankfully, these have become very rare in our country now, for most parts of the country. So the question is, how much factor level do we need to be reasonably safe? So 3 sets of data, one of which, yeah, you can see that there. On the left is observation from the 1960s, reported from Malmo, where they made a very simple observation that if you have more than 1%, you will not bleed so much. So the goal that Inga Marie-Nilsson taught us is that we must somehow give plasma, cryoprecipitate. Those days there was no factor. Then plasma-derived recombinant factor to keep above 1%. And we tried to live with that because no better product was available. Then came data from Netherlands, which you see in the second set, where they observed people with mild moderate hemophilia and showed that if you had more than 10 to 12%, you could actually do a good amount of sports. So the next target became 10 to 12 in an era when we were having extended half-life products. Before that, we couldn't even imagine that you can reach those levels. So with the factor 9 extended half-life products, not only was there clinical observation, but there was a product to match it. So there was a purpose in pursuing that. And then 2018, what you see on the right is data on observation of almost 5,000 patients from the CDC from USA, where they showed at what level does your bleeding reach kind of normal population. And that number there is somewhere between 20 and 30%. So that kind of matches, even the surgical hemostasis that we were practicing earlier. So from all this, if you want to do gene therapy, at least 5%, but preferably between 20 and 30%. So keep that in mind as we go forward with what happens with gene therapy in the world, okay? So what is gene therapy? In the classical sense, it used to be that a particular gene is not functioning, and you construct a normal gene outside the body, you put it into some kind of a vehicle which is called a vector. It can be a viral vector or a non-viral vector, and then you give it to the patient. It may be given by different routes. Some diseases they give it intramuscular, some intravenous, and for hemophilia, initial study that we were trying to do in 2004 or 5 was intra-arterial into the hepatic artery, directly into the liver. But all that was not needed. For now, the approach mainly was intravenous. Whatever you do, it has to reach the cell in the body that will accept that gene and make it function. So in hemophilia, it has mostly been liver directed that we have tried to transfer the gene, except till very recently. So here, as you see, the transgene is made, it is put inside a vector, it is injected into the person, and it goes to the target cell where the gene functions, makes the protein. The same for thalassemia, sickle cell disease. You give a beta globin gene, they will make hemoglobin. And so, they'll make the globin that will become hemoglobin. Two approaches. One is called in vivo, where the vector itself is injected into the person and it goes to the tissue of interest, in this case the liver. So all the AAV gene therapy, adeno-associated viral vector gene therapy, is directed towards the liver. You inject in a vein, it goes to the liver, the gene is delivered, it starts making protein. There are pros and cons. Now here, the major problem for us is in India that somewhere between 70 to 90% of people have anti-AAV antibodies. So that excludes you from being eligible, because the moment the vector is infused, the antibody will neutralize it, it will never reach the liver. And second, require the liver to be mature, which happens by maybe 12, 14 years of age. So we cannot treat children under 10. So by that time, these children would have had so many bleeds and joint problems. So we want something that can be done much earlier in life. So the other approach which has been used for immune deficiency disorders, thalassemia, sickle cell disease, whereas you take out a cell outside the body, in this case the hematopoietic stem cell, and you put the gene into the hematopoietic stem cell, then no antibody issue, no age issue, no liver size issue. But the other one is a simple vein infusion in the outpatient clinic. This one you have to collect stem cell, take it to the lab, you have to modify it and do a transplant. So there is big process before the gene therapy is complete. So as I said, we started thinking about this more than 25 years ago, and we made an application to the DCGI with one of the first sponsored clinical trials for hemophilia B using recombinant AAV. Unfortunately, that trial closed before this application was processed in India, so it never went on. That trial didn't go very well. The third patient got some transaminitis and they closed the trial. But almost 10 years later, Amit Nathwani reported 10 patients where 6 of them who had got higher dose of AAV8 at that time could maintain about 5%. And the editorial which went with it, they say, Merry Christmas. This was reported in December, so Merry Christmas for hemophilia B. So our expectations in 2010 to 14, when we did not really have too much experience with extended half-life or emicizumab, we were happy to call 5% cure. But then what happened is that, this field kind of lagged for not understanding immunology of AAV-based gene therapy, and so it took a long time, almost a decade, before things moved forward. So it was only in 2022 that you are seeing this first hemophilia A AAV5-based gene therapy with a very high vector dose. You see that 6 into 10 to the power 13. Imagine infusing that many viral particles into the body. It actually exceeds the total number of cells we have in the body if you take, multiply it by the body weight. So, of course, we got wonderful factor VIII expression, and what you see there is in the first year levels going 100 to 400% almost. People were worried, will some of these hemophilia patients get thrombosis because the level is more than 200%. But slowly it started coming down and down and down, and that's the problem. Over 3 to 5 years, now between 5 and 15%. So it's not bad. 5 to 15, it is not 0. Some are going below 5 also. So the unpredictability, and here, even though the infusion was very straightforward, almost a large number, more than 50%, landed up with transaminitis, liver inflammation. And that transaminitis was associated with drop in factor levels. Again, all immunological issues, I don't want to get into details today, but a lot of these patients landed up getting steroids to reduce this transaminitis. So post-treatment, even though the treatment was so simple, they were on steroids with all kinds of complications and these levels going up and down and unpredictable. Who will get how much? Will you get 50% or 400%? After 2 years, will you have 5% or 50%? And that's the problem that has been in this factor 8. Factor 9 was better because remember factor 9 is the natural place, I mean the hepatocyte, the liver cell is the natural place where factor 9 is produced. Factor 8 is not, it's in the endothelial cell. We are forcing the poor liver cell to make factor 8. You're putting the gene there and saying make factor 8. So in this case you find the levels are more stable and this is been more successful, but the transaminitis issue is here as well. Some steroid therapy is needed, post gene therapy here as well. So those are still some concerns. And so for this was the first factor 9 product, and only last year we got the second factor 9 product from Pfizer. Again, very similar data, some levels of unpredictability, but much less than factor 9 and more stable levels than factor 8. So finally we had 3 products. Between 2022 and 2024, we had Roctavian, the only one for factor 8. Then we had Hemgenix and from CSL and Bequez from Pfizer. The pricing, depending on whether it was maintaining level or not, the factor 9s were in the $3 million range and the factor 8 was at $2 million range. But the tragedy is this, see what has happened in the last 5 months. In December, Roche terminated because the hemophilia A gene therapy with AAV is not going very well. Okay, so already Roctavian Biomarine has announced that they will market in only 3 countries: USA, Germany, and Italy. The rest of the world they are not even interested in marketing because they know there is no market. For 2 years after registration, no government showed much interest. So it means it is not going very well at all. The Hemgenix is still registered everywhere, but the uptake is less than 20-25 patients in more than 2 years. People are not so excited about it obviously in the community. And Bequez has been formally withdrawn in February this year by Pfizer. So AAV-based gene therapy, after 20-25 years of research, 3 products registered, 2 almost gone, and the third one not good uptake. So it's not very good positive news for AAV-based gene therapy. And this is the data I don't want to explain. You can see at the end of 5 years, the Roctavian, the levels are dropping so much that, and there are so many other options now for these people in the community. So why go for something like this? So this is where some of our data I want to show you. We realized this problem with AAV more than 10 years ago. It took us a long time to get to the point of doing an alternative, completely new approach for gene therapy, which, as I had explained to you earlier, we construct the factor 8 transgene. We make it in a way that it actually secretes much more than the normal transgene. This is really a sequence modified transgene. Then put into the hematopoietic stem cell outside the body, and then the patient undergoes an autologous transplantation so that these stem cells can go in and grow in the body. So that's the concept. And the factor 8 is not expressed in the stem cell, but it is given a promoter which will make it express only in the blood cell that circulates, monocyte, not in the stem cell in the bone marrow. So with that, again, without getting into details, what this involves is you identify the person who is suitable. Most people will be, and the good thing here is at any age. Once we show safety, if we are able to do all the trials, then it can be done at 1 to 3 years of age as well. There is nothing preventing doing that. So you identify the patient, you collect their stem cells. This is a very standard procedure that is done for, in many hospitals. You take it to the lab, and just like CAR T cells that some of you will be familiar with for cancer, you take it to the lab, you introduce the same lentiviral vector transgene, which many centers are already doing in India for CAR T cells, and then you bring it back and do an autologous transplant. And that is on the right side of this slide, where you admit the patient, you give them treatment to reduce the bone marrow cells, and then you infuse these cells, and within about 2 weeks to 3 weeks, these people are normal. And the good thing is, at least the 5 patients we've treated so far, don't need any more care after that. These people are just normal and they walk around. We just follow them because they are on trial, therefore we must no intervention of any kind. So it's a very different. So this was obviously it was a phase 1 trial for safety, but we wanted to see some efficacy effect. Those were the inclusion criteria. This being the first one, we took only adults, but as I said, this technology can be easily applied to very young children, and anti-AAV antibody is of no significance. The The manufacturing requires some skill and you need a good lab to do that. So initially we were doing manufacturing by a certain technique which we modified after the first 2 patients. So the first, this is the first gene therapy trial in the world where the first patient showed a response. Usually the first few patients have never shown response and they are kind of the experiments, so to say. Only after that people learn, change dosage, and then you see response. Here we were fortunate, the first patient showed response, but it was low, and therefore we modified the manufacturing protocol, and then we got better responses. And this is the data. So these are, this is published in the journal, you can access it anytime. 22 to 41 years of age, all severe hemophilia, a lot of bleeding in the past, multiple joints affected. We gave them a good cell dose, and this is the data at a follow-up of about 9 to 27 months. We use conditioning, just triosulfan fludarabine against very low toxicity, even to our surprise. These are data for people, hematologists here who may be familiar with transplant, very, very low toxicity. Almost no mucositis. In fact, there's a paper from Copenhagen, recently, where this conditioning for blood diseases, not for hemophilia, they are doing these transplants as an outpatient. So, and we were really thinking, obviously you can't do it as an outpatient in a clinical trial, but finally it may become as simple as that. And the most important thing is, one of the concerns is when you give drugs like this, you may lose fertility. But all our patients recovered their sperm count after about 6 months. So that was a real surprise for the world actually. So how did they do with the bleeding? Amazing results. All these patients are as active as they can be. One of them even managed to have a motorcycle accident and fell down and banged his head on the road and was unconscious for 30 minutes but did not bleed. He had 40% level. Okay, so that factor is really working. If you bang your head on the road and be unconscious for 30 minutes and then you find that the CT scan does not show a bleed, you are doing well, right? So this is real data, and it is persisting. It is now 6 months more since we reported this, and all these patients are maintaining their levels. So what you can see there is that the first 2 patients, very low levels, 2 to 5%, but enough to keep them bleed free with normal activities. They're not climbing mountains. But the others, running between 25 to 55, 60%, they're falling off the bike and hitting their head on the road, and so far nothing happened. So, and the interesting thing is that the levels are maintained, it's not going down. Okay, so this is good. So this is the good news. What's the bad news? Well, the other good news is that the editorial in the journal thinks that this technology can overcome the limitations of AAV, which is a good thing for somebody else to say. So as I said, this is the good news. What's the bad news? Bad news is that why are we just talking about this result 1 year after completing it? Why are we not in phase 2? Why is this vector not manufactured in India, and why is phase 2 not started so that in a year or 2 from now we can have a product in the market if the results have? So the tragedy is that science is not always about letting people do what you can do. There are people who obstruct progress, and unfortunately that's the reality with this now. The institutions involved have delayed progress. That's a very bad thing. I'm saying it in public forum. We're trying to overcome that. It will be overcome, but we've lost 2 years. That's a tragedy. And to me that's bad news, because this is amazing results for the moment that would help so many and bring this first in the country, first in the world, but it has been delayed. So with that I want to stop and acknowledge, of course, now why is this not moving? So of course, thank you. So all the team at CMC Vellore and the Center for Stem Cell Research, but really long-term, more than a decade support from every university. Our understanding always was that we will own the product if we show it's good. So it's not a sponsored study from anywhere else. It is a product that India can own and manufacture here, and the support from the Department of Biotechnology, Government of India. They had amazing support throughout this period, and also some from the US. Most importantly, the patients. It's very different when you tell a family or a patient, nobody has had this in the world, you're going to be the first one. Okay, we don't know what will happen. There's a small chance you could have very serious complications. less than 1% chance that you will not survive, but it can't be zero. Those are very difficult conversations. But when you have families that have been associated with you for more than 2-3 decades, it was, we're really grateful for those who agreed to participate. Thankfully, each one of them responded. We couldn't have assured that, before the trial started. With that, I'll stop and thank you for your attention.
Does anyone from the audience have any questions for Dr. Alok?
Early patient who's in US wanted to have a therapy in India. Quite, I was told that recently they have in US they are not doing it now, of course, because of their problems. But here it was told.
So, Octavian and Hemophilia are both available in the US. Nothing is available here right now because it's a clinical trial. I'm telling you that Octavian and Hemogenics is available in the US for use if you go to the right centers and are found eligible by their criteria. CMC was only a
I
center.
got a reply.
Yeah.
Recently stopped.
Cannot do because there is no vector. So when we produce the vector, then a phase 2 trial will start, and it will be a trial, Dr. Nalini. It won't be a therapy that anybody can access. He'll have to fulfill the criteria for the trial, and
That
then
of course.
Dr. Hita. You're talking of AAV-based gene therapy, and if they have high titer inhibitors, there are possibilities of removing those inhibitors, but nothing that has been formally tested even in a clinical trial. So theoretically, there are ways to reduce those inhibitors, but will it reduce enough to be eligible for gene therapy? The answer is no for the moment. Yeah, so I showed you the duration of, maybe I went too fast. So the normal in autologous transplants for lymphoma, myeloma, the cytopenia is 10 to 15 days in that range. Here they were all below 10 days. Thrombocytopenia was actually less than a week. So the most important thing is that they had no mucositis, so they were sitting in the room eating their normal food. And that is how I was really pleasantly surprised to see a report from Denmark just 2-3 weeks ago that using this kind of protocol, they are doing outpatient allogenic transplants. Cost is always determined by the company that but we are very much hoping that this will be in the range that the government will support. We now know that the government has a policy of a certain support for rare disorders, curative treatment. So something in the 25 to 50 lakh range, I hope we can bring INR, not dollars.
Viral hepatitis.
So, very important question, and I have a very positive outlook on that because, as you know, we have done more than 800 transplants for thalassemia allogeneic using triosulfan, and those older children and some adults have tolerated triosulfan conditioning for thalassemia allogeneic transplant. The autologous transplant is much simpler. So I believe that even older patients with hepatic dysfunction will be able to undergo this gene therapy, but obviously it will be after the trials are over and it gets registered in a.
Thank you, Dr. Alok. Dr. Alok, I would like to request you to please remain on the dais so I can call upon Mr. Premrup Alva, President, Hemophilia Federation of India, to kindly felicitate Dr. Alok Srivastava. I would like to apologize and ask the both of you to kindly remain on the dais because you also will be playing a huge role in the next session. So up next we have the launch of the treatment guidelines for hemophilia in India. So I would like to invite Dr. Bipin Kulkarni, Dr. Meera V, Dr. Neeta Radhakrishnan, Dr. Sita Lakshmi, Dr. Jasmina, Dr. Sheikh Bilal, Dr. Venkatesh Palekar, Ashil Kale, Dr. Parul Bhatt, and Dr. Tulika Seth on stage, please. I would like to also welcome Dr. Nalini on stage, please. I would like to welcome Dr. Nalini quickly too. Before we start, we have a special video message from VP Medical, Dr. Cecil Ross. So I would like to kindly request the IT team to play the video. With that, I would like to request the HFI Treatment Guidelines Committee to please launch the National Treatment Guidelines for Hemophilia in India. Thank you, HFI. Thank you, HFI Treatment Guidelines Community. I would like to welcome Dr. Alok to say a few words, please.
All, I want to congratulate HFI for this initiative and especially acknowledge the amount of work that Dr. Cecil Ross put in with all the people here and some who are not here in putting this together. I want to just recall, actually Dr. Cecil Ross mentioned 2010. It was actually 2005 when we first wrote up the HFI guideline first edition, a very brief but I tell you that experience, and that took us 2-3 years. It was in 2003-4 that I joined the WFH Executive Committee, and I challenged them, having done a little effort in India. I said, how are you going around the world and telling people what to do without anything standardized in a guideline? And that's how the HFI, I mean the world, actually I correct my dates. The HFI first edition is 2000. World Federation first edition is 2005. When I challenged them in 2003-4, they said, okay, how can we do it? And anyway, we did something. The 2005 edition looks like a rag now, if you compare it with the second edition in 2012. But it was always meant to be adopted and adapted. Adapted is the word. Because whatever we write nationally, now in the states, people have to look at it. Whatever we write internationally, people have to see how it adapts to their conditions, their country. So this is a great initiative, as Dr. Cecil said, a lot of it has been of course taken from what the international recommendations are. But even within these, you will find that you may have to modify according to what the state selects as products, what the diagnostic facilities are in the state, what the approach, because there will be variations within a big country like India. So take this as a guidance as it is meant to be, and really work with the local NHM and the DHS authorities to see how this can be implemented within each state in our country. Thank you.
Dr. Alok. I would like to ask Dr. Parul Bhatt to say a few words, please.
Good morning all. This is a great achievement for on the day 17th April as a Hemophilia International World Hemophilia Day. This is what really we want to make it uniform treatment strategy for all the states. So this will going to be helpful to all state stakeholders as well as to convince your authority also. So I think this is a great opportunity for all of us to work together for betterment of the hemophilic patient and all the society. So thank you very much for giving me this opportunity to be a part of this thing. And once again on World Hemophilia Day, I wish you all a very happy, healthy and very long life. Thank you very much.
Thank you, Doctor. Next up, I would like to invite Mr. Harshal Kale, Regional Manager, World Federation of Hemophilia, to say a few words, please.
Thank you. Happy World Hemophilia Day to everyone. Uh, this is a fifth year of a WFH project PACT, which is a flagship program of WFH, and I'm very happy to see that this guidance document is being launched in the last year of the PACT program, and I want to thank all the esteemed doctors who contributed to developing this guidance document. The first roundtable we had in 23, then 24, and now we have launched this document. I really hope that this document can work as an important advocacy tool in each of our state, and in turn it can lead to like a state-specific guidelines and a national guidelines very soon. So thank you so much to everyone who contributed, and uh, and I hope that our advocacy succeed very soon. Thank you so much.
Harshal. Next up, I would like to invite Mr. Prem Rupalwar to say a few words, please.
Happy World Hemophilia Day to one and all. Firstly, I think it is indeed a very, very good contribution in this book. It's a great thanks from all the doctors who have contributed putting this initiative. It took 3 years in the making. But the idea is we are not calling this as a guidelines, it's a guidance. So, and it is, India is, healthcare in India is a state subject. Refer to these guidance provided by the best, in fact, not only in India, in the world, I would say. Our doctors are definitely, I've always told this to the World Federation, that our doctors, our researchers are the best in the world, because the sheer number of people all of you see. We are in a different league. This guidance document is made basically for the doctors of the government and the bureaucrats, so that you can adopt whatever your technical committees and your committees in the state can adopt. It's fantastic. We're not saying this is guidelines. Please adopt it. This is a guidance for you to build a guidelines. Thank you so much.
Thank you, sir. With that, I would like to thank all the delegates on the stage and the HFI Treatment Guidelines Committee for your immense hard work to make this possible. Thank you. The next session we have is the Industry Symposium. We will be starting our Industry Symposium with our first talk, which is Unmet Needs Driving Innovation by Dr. Tulika Seth on behalf of Novo Nordisk. Maybe we will circle back to that talk in a little bit. Next up, we have Pfizer's commitment towards hemophilia care, Dr. Hitesh Mule and Dr. Komal Kaur on behalf of Pfizer. We will probably circle back to that talk as well. Next up, we have APCC in patients receiving non-factor therapy. Go to the fourth talk, because this is also Dr. Tulika Seth. The fourth talk on, oh, she said, okay. In that case, we will go to the first topic, Unmet Needs Driving Innovation by Dr. Tulika Seth on behalf of Novo Nordisk.
very much. This is such a wonderful meeting with all of my dear friends and colleagues, so many people from the government from all over the country. So this is a topic that all of you are very much aware about. I don't need to dwell on the advances that we've had over the years in dealing with hemophilia. There have been many, many advances, and it's because of these advances we are all here today to discuss and deliberate. But it has been a fascinating journey from the 1940s, 50s, and 60s, where we really didn't have anything but blood, and we know the consequences of that. We know the purified plasma-derived factors were a boon to us in India. And then we are very happy to have recombinant factors, both the standard half-life as well as the extended half-life. And now we are in the era of non-factor therapy. So the excitement is definitely going to keep increasing and increasing as we have access to better and more good products for patients. So if we have so many things, are there unmet needs? Unfortunately, there still are. We know that patients still face bleeding episodes even though patients may be on prophylaxis. We know that patients have a huge physical burden because of their poor physical health and limited activity. We know that the quality of life is really poor, and we've conducted a study recently on the psychosocial impact of hemophilia. We were fortunate to have a person with hemophilia who is a psychiatrist himself, and he did this as a DM thesis, and this has been accepted as a paper. So we know that there are many issues, and part of this is due to the burden of administration of intravenous products. So for factor 8 products, we know that patients will be getting alternate day intravenous injections, and for factor 9, twice a week intravenous injections, which comes to many hundreds of injections over the year. So our patients with on prophylaxis, so that even patients who are on intermediate or high dose prophylaxis, the ABR rates are rarely zero when we use standard half-life products. And this was something that we battled with a lot when we started prophylaxis, that even though we're doing prophylaxis, we are not going to be low ABRs. And we know that patients can still continue to have subclinical bleeds. So there are even patients who may not have a known bleed for which they went to a doctor, but they can still have very poor joint health because of these subclinical needs. The effective treatment options have currently been the standard half-life products as well as the extended half-life products. In patients who were on this with hemophilia, we know that the number of bleeds in patients on extended half-life is less, so that is something important. And the patients who were on non-factor products, again, these spontaneous bleeds were less in these patients. Patients with inhibitors are at an even more disadvantage because the treatment for inhibitor patients currently available are even more expensive and less accessible. So once a patient develops an inhibitor, their quality of life, their bleeds, everything becomes even more difficult. And more patients need hospitalization. During COVID, we unfortunately even lost some patients with inhibitors due to these problems. So if we're able to provide good care, we should have good joint health. And often, if we have good joint health, we can avoid the arthropathy, pain, and the need for surgery. And one of the important drivers of arthropathy are target joints. And we see that many of our patients in India, evidence suggests that the physical activity remains lower in people with hemophilia than in the general population. And this is a lot due to the fear and the overprotection of the parents, and also because of the experience that they've had with the bleeds, and many times with the initial synovitis and beginnings of arthropathy that patients have. The quality of life is something that we've not really looked at too much in our day-to-day practice, but we know that there's a substantial physical, emotional, psychological, and social burden on these patients. There have been some very good publications which have come out on this. So, and a lot of this is the fear that people have that when they go out, they may get a bleed, and this fear leads to the anxiety and depression. This we've already covered, that the inhibitors deal with result in a poor quality of life. And the intravenous administration is a problem. Every year during the summer vacations, we have camps where we train the parents and the older children how to do intravenous injections with the various dummies that we have in our wet lab. But it's a skill that needs to be learned, and there's initially a lot of fear with that. And so having intravenous products is definitely useful, but having subcutaneous product is going to be much, much better. And even with the subcutaneous products, there's still some limitation, because if you have to inject yourself with any needle, that is sometimes quite frightening for people. People do have fear of needles. We need to make sure that we have home therapy. Currently, this is something in India that very few states are participating, which is home therapy. If you don't have home therapy, then obviously there's going to be a lot more absenteeism, and there's going to be more hospitalization and absence from school and work, and you're not being able to give the product at the earliest time. There is some studies to show that if you can give the factor early, you may actually require half the amount of factor. But there are many barriers to this. One is, who's going to store this? Do we have enough supply? People have to be expert enough to give injections, even if it's a subcutaneous injection, and definitely if it's an intravenous injection. We have a lot of advocacy and motivational issues related to that. So how can we, now that we know all the unmet needs, how can we move forward? I think first of all, it's really important to have meetings like this where we all get together and we talk about it. And we also need continuous innovation. And if we can think of newer modes of drug delivery, and one of these newer modes of drug delivery that we have is, especially for the non-factor therapies, where because these products are able to actually rebalance and initiate coagulation and hemostasis in a different way, they are going to really revolutionize the way that we've looked at hemophilia as a deficiency, and where we only replace these deficient factors to a situation where we're now normalizing hemostasis and rebalancing the things. So now there are many newer drugs. We have RNA interference therapies that block the antithrombin synthesis. Tissue factor inhibitors are one of the targets that are there. And there's several isoforms of this, and we have drugs that can bind to this and be targets that can balance the coagulation cascade. And we know that TFPI is a potent regulator of normal coagulation, and we can increase the thrombin generation, which then prevents the bleeds in these patients, and it can work in both hemophilia A patients and hemophilia B patients. So these are some new things that we're hopefully going to be having further. There are other factor 8 mimetics that are coming up, and these are engineered specifically, and they are very safe and efficacious. There's a lot of interest in looking at this. These products are able to optimize the clotting cascade, and again, they're able to prevent any non-specific binding without, while at the same time providing factor 10 activation, which is very important, as we all know, for the clotting cascade. And how do we deliver these? The innovations are also there in the delivery of devices. So the delivery devices improve adherence, and they also, especially the pen injector, which is something that we've used on a study, they increase the convenience, they simplify administration, they're very user-friendly. Initially, when I got to know that this pen injection device was required to use daily, I was a little worried. But patients take a bath, they inject themselves with this pen injector, which is basically simply the amount of pain is like as if you take a ballpoint pen and you sort of press it into your leg. There's very little pain, it's very convenient, and it makes the patient feel protected all through the day. And it was very simple to train patients, even for the adolescent patients that we had. With just simply one demonstration, they were able to do it on themselves, and we've seen very good compliance and very little complaints. And the total amount of training that they've said is 7 minutes and 49 seconds, but I think for most of my patients, I was able to do it in even less than 5 minutes. So it's something that is really, really useful and is making these treatments available for home therapy. And I think this will really revolutionize it. And when we look at the patient-directed outcome outcomes and their opinions, most of the patients felt very comfortable with this and they found it much easier to use than any of the other options that we have. So I think it's really important now to change the goals of treatment. We've treated persons with hemophilia as patients, and I think now we need to empower them and to listen to them and to make sure that we are able to integrate them into society to help them fulfill their full potential. And this is a lifelong disease, so it needs normalization, and we need to make sure that we are able to accept these patients and we're able to provide a multidisciplinary team to ensure that we have very few complications and disabilities and we allow them to lead as healthy a life as possible, which is what their rights are. So with that, I thank you very much.
Thank you, Dr. Tulita. So up next we have Pfizer's commitment towards hemophilia care by Dr. Hitesh Mule and Dr. Komal Kaur on behalf of Pfizer.
All, thank you very much for this opportunity. Myself, Dr. Hitesh Mule, I am the commercial lead for rare diseases at Pfizer. Along with me, or she is our medical lead for the rare diseases at Pfizer. We are quite excited and feel honored to be a part of for this particular event because what at a Pfizer we think we believe in the cause and definitely we are together in this journey to improve the life of a patient who are suffering from hemophilia. At this point of a time, we have a limited products that are available in India, but our endeavor is to see how we can partner and collaborate so that the standard of care in hemophilia. This is the disclaimer that we want to start to begin with. The programs or the some information which is mentioned may not be complete or is confidential at this point of time. For information purpose and all products may not be available particularly in the India. What we speak does not take into a consideration that it should be taken as why we think about the Pfizer. Like at a Pfizer, we are present in this therapy area for the rare disease for more than 3 decades. We do have an experience and globally when we look into where we are currently focusing in these therapeutic areas is primarily the hematology which have a presence in other therapies like neurology, endocrinology, cardiology and other enumerated disorders, but the therapy which is close to the heart at Pfizer is a hemophilia which is a rare hematology. What we are currently looking into, it's not like we are having all the products that are related to the hemophilia, but the breakthrough treatment that currently we are looking and endeavoring to identify the unmet need and address the problem includes small molecules, large molecules and monoclonal antibodies. And couple of devices also. Potentially what we are trying to address, can we have some indications which will help us address the unmet need of the patient and probably can it help us improve the standard of care for the patient, and particularly if it is related to the hemophilia, we will be more than happy because when we look India, we are the second largest population with the why this is very close to the Pfizer when we think about hemophilia, because collectively the rare disease portfolio that globally and locally that we focus into, the important component is the hemophilia because we are large patients of hemophilia, people with the hemophilia are present in India. Therefore, it becomes very important that this section is taken care of, because though we are slightly fortunate to do have some treatment options for hemophilia, but for the rare disease, if we look into, there are very few treatment options that are approved, and generally it takes a longer time. We have done a phenomenal work diagnosis, increasing the time and accuracy of the diagnosis in India, but we are far more from sharing it or exploring it for the other therapy areas. And this is the learning that we can definitely take from the organizations that we are currently looking into. Fortunately or unfortunately, the genetic diseases starts into the patient, which puts a lot of burden on the human society, and therefore it is important. And probably we want to take an effort to reduce the quality of life of the patient, those who are suffering from. When we look into the rare hematology, what it is important, point of a time, we have done a phenomenal development or advances in terms of improving the diagnosis, but yet still there is a possibility that we can improve the quality of life of the patient by offering them a treatment that renders them live their normal life. We have significantly improved the life expectancy with the effort from all the stalwarts, those who are driving this therapy area sitting into the room, but yes, we can definitely join hands together so that we can improve the quality of life and bring them back to the normal life expectancy. We understand, according to the World Hemophilia Federation, they clearly mentioned that there is a need to improve the diagnosis. India being a huge there is a chance that we can improve the diagnosis of the patient, bring them under the registry. All sets of a patient that we are currently looking into, they are identified, and therefore we can offer them a right treatment. Then we can improve the diagnosis of the patient who are currently not diagnosed, as well as bring them into the registries. What we currently highlight, in India we are the great example how we should manage this particular hemophilia, because the limited resources, challenges, wide geography, how we can take care of it. But yes, there are a lot of challenges that we look into. How we can improve the access to this product, how we can improve the infrastructure of the centers that offer this particular treatment, and on the top of that, how we can improve the health literacy of the individual so that they understand how they can successfully deal with this particular detail, and the healthcare fraternity. All the healthcare specialists, they look at the hemophilia as an option to bring those people with hemophilia suffering back to their normal life. With this, what we have as an options into it, I would request my medical lead to speak about that. So thank you very much for having us here and giving us an opportunity to be a part of this cause and in an endeavor to win this particular race and bring back the hemophilia patients and people with the hemophilia back to their normal life.
Good morning once again. I am Dr. Komal Gaur. I am the medical lead for rare disease portfolio in India. While Hitesh did highlight about the diagnostic challenges as well as the infrastructure challenges, our presence here is a commitment to the fact that Pfizer is here for the innovative therapies, and the slide here shows the pipeline of Pfizer globally. While the pipeline snapshot does mention about all the products which are under development, what you see on the lower part of the slide is some of the specific products which are under focus globally as well as in the country for hemophilia specifically. And this is a continued commitment not only on hemophilia but also the other hemoglobinopathies, and as the development progresses, we will be happy to share those updates with you all, with all the fraternity right here. Has been a key focus for Pfizer, and significant progress has been made over the year, and continuously the research and development department of Pfizer has been developing therapies in order to ensure that we improve not only the management but also the diagnostic as well as the infrastructure capabilities across the globe. Considering India has probably the highest burden of patients in the country, it becomes all the more important for us to focus on how do we improve and bring in these therapies as early as possible in the country. And this is the last slide where it shows the journey which Pfizer has been traversing in terms of bringing the scientific innovation in the hemophilia space. While it all started in the late 1960s, and we are in a stage, while it started with the standard factors as well as the EHLs, we are at a stage where we are now evaluating the possibility of the non-factor therapies as well as the other innovative therapies in this space. So again, this was the last slide just to share our commitment from Pfizer that we are here to partner, we are here to collaborate not only with the hematologists but also with the patient groups, with Hemophilia Federation of India and all the relevant stakeholders for ensuring that we bring these therapies as early as possible in the country to improve the care of the patients. Thank you so much.
Dr. Hitesh and Dr. Komal. I would like to ask Mr. Ramu Gadkar, Vice President Development, to kindly felicitate Dr. Hitesh and Dr. Komal. Hitesh and Dr. Komal kindly join us on the dais. Session. Next session is APCC in patients receiving non-factor therapy by Dr. Tulika Seth on behalf of Takeda.
So, just as all of us are here as good friends, all of us have our own people who support us and who are friends with us. So similarly, we need to have many, many products. So all of you must have a friend who helps you when you're feeling sad, maybe a friend who helps you in different problems at work or in life. So similarly, I think it's really important that we not forget the older products that we used to have and which have really helped us over the years. And I think that there is a space for all of the things that we have, both the old and the new. So that's why I'm quite delighted to discuss here. These are my disclaimers. So we know that there's APCC has been with us for many years. Initially, we have been using this for patients with inhibitors, with patients with severe bleeds. It's also used as a reversal agent for anticoagulation patients. And then we had many new products that came in, and I think obviously our patients, when they hear about new products, they want us to prescribe them, and I think it's perfectly fine to use these newer products that we have. We have many new non-factor products, we have the extended half-life products, so it seems to be a very busy space. But I think it's important to understand that even when we have these non-factor products, there will be patients who, even with inhibitors or without inhibitors, who will have bleeds. There will also be patients who are on non-factor products who may have a requirement for surgery or may have very serious bleeds like intracranial bleeds or psoas bleeds. So at that time point, we may need to figure out what else is required additionally for these patients. And so there is a space, I feel, for the conventional bypassing agents that we have been using in our patients earlier as well. Now, in the studies that were there for emicizumab, there were patients who had bleeds, and these were in the joints, more than 70%. And these joint bleeds we know can lead to the irreversible damage and structural changes. So having a patient even with a single bleed may be very important. And of course, if a patient has bleeding at the gastrointestinal tract or the intracranial bleeds, or as I said, the psoas bleeds, then these can be life-threatening, and it's very important that they are treated. So there has been concerns of patients who are on non-factor products like emicizumab when they were given the bypassing agents. And most of the patients initially when the studies were started were given APCC, and some of the patients were also given recombinant factor 7A. And because this was all very new and it was a study and people were learning and experiencing, a lot of things happened at that time from which we have now learned. What we figured out was that in the initial Haven 1 study, there were 130 uses of emicizumab along with APCC co-treatment. And the majority of these patients were given different doses at different time points and different frequencies. So some patients were given less than 50 units of APCC, some were given between 50 to 100 units of APCC, and some were given more than 100 units of APCC per kg per day. And again, these were given at different time points for treatment of bleeding, and many patients on the study at that time were given multiple doses of APCC as well. And a few of these patients, three of, to be exact, out of the 130 patients developed thrombosis, and these thrombosis were treated at that time, and they were done and they happened because of the repeated doses of the APCC that was given. So if we look at the real world data, the Stacy study, of which many centers in India were also participant, at that time they had only 2 out of 195 patients who had a thromboembolic phenomena, and no TMAs occurred. Versus in the study, there were about 2.6% patients, so 5 out of 192. And after that, there was some extra vigilance that was recommended, and patients were advised to either be treated only with recombinant factor 7, or and that continued for some time. But then when we go more into the detail of the Haven 1 study, it's a little small, so I hope you can see, but if you see this, patients received multiple days of APCC and multiple doses. So if you see from this, but if you see the first block, you can see patients got close to 100 units per kg, and they got it on multiple days. Some patients even got several doses in a day, making their total amount administered was more than 100 units per kg. So of these patients who got more than 100 units per kg, these were the ones where the thromboembolic phenomena or the TMA were diagnosed. So in India, first of all, we don't usually have that much availability, and even if we do, we tend to use maybe 50 units per kg, then monitor and assess the patient, and if needed, maybe administer another 50 units per kg, rather than administering very large doses again and again. So with that knowledge, I think a lot of experience has come, and we are much more comfortable in treating breakthrough bleeds in patients with non-factor products like emicizumab. And currently the guidelines are that yes, you can use recombinant factor 7, but you can also use a reduced dose of APCC. The dose recommended is 100 units per kg per day maximum if needed. The patients did very well with even a 50 unit per kg single dose. There are many newer non-factor products coming up, and I think that's why we need to continue to have these kind of dialogues to understand these products and to understand what to use for patients when they do have a bleed, and make sure that we are learning from the studies and combining that information into our practice to ensure safety for our products on this. In the concizumab Explorer 7 study, when patients had breakthrough bleed, they could be given the standard dose of 90 units, 90 micrograms per kg of recombinant factor 7, or they could be given a single dose of less than 50 or less than 100 units per kg of APCC. And this was allowed as per the investigator discretion, and this was proven to be very safe. In the Fitusuran Atlas study, again, if patients experienced a bleed, they could be given 45 micrograms per kg of recombinant factor 7 or 30 units per kg of APCC, not exceeding 50. So if we follow these parameters, whatever is available, because I know at many centers you may have one or the other of the bypassing agents. So if we follow these rules, you can safely manage patients who have breakthrough bleeds with inhibitors on the non-factor products. And by using the lower doses, you will also be cost saving. And the patients who, there were about 40% of the patients on the concizumab Explorer 7 study who had been treated with bleeds, and only one patient had a thrombotic event, and that was actually a renal infarction, but that was actually a patient who had received factor 8 therapy at high doses along with the concizumab. So this was actually a non-inhibitor patient who was self-administering factor 8. And in the fitusiran study, there were 2 patients who received APCC and 11 received recombinant factor 7A, and there was no increase in the adverse events treated in either of these groups of patients who were on the fitusiran prophylaxis. So the key takeaway is that yes, even with the non-factor prophylaxis, patients can have bleeds, and if they have bleeds, it's important that we treat them, and we have 2 conventional bypassing agents, and both of them should be available to you. In case you have APCC, it can be safely used as long as we don't exceed the daily dose which is recommended, which is you shouldn't exceed more than 100 units per kg per day along with these products, and often much lower doses of only 30 to 50 units per kg per day can be quite efficacious in managing bleeds in some of the newer non-factor therapies. And this is a very important message that we must share with our teams as well as the administrators so that there is no concerns. So with that, I'd like to end. Thank you so much.
I would like to request Dr. Tulika to please remain on the stage. I would like to request Mr. Jagdish Sharma, Vice President Finance, Hemophilia Federation of India, to kindly felicitate Dr. Tulika Shetty. Next presentation is on congenital factor 9 deficiency, from diagnosis to replacement treatment with pure factor 10 concentrate, congenital factor 10 deficiency, by Dr. Stephen Kenneth Austin on behalf of Alpha Drugs.
I'm a hematologist in the UK, and great pleasure to be able to contribute to your program today and to help celebrate in World Hemophilia Day. But also I have to say thank you to the sponsors, Kedrion, for producing a plasma-derived factor 10 product, which I will discuss with you today, which has certainly transformed the lives of my patients with severe factor 10 deficiency. In 2026, it will be 70 years since 2 groups simultaneously described the first cases of factor 10 deficiency. And you can see on the right there Rufus Stewart, and on the left Audrey Prower, who was in the UK. And so together they were the first patients with a bleeding phenotype and coagulation screens that were prolonged. Subsequently we identified as having factor 10 deficiency. Subsequently we named factor 10 as also called the Stewart-Prower factor. We know a lot more about factor 10 today than we used to know. Factor 10 is integral in the prothrombinase complex. It is the main reactant in the common pathway, so it's vital in the response to tissue injury, and also not only in the small amount of thrombin production that is made, but also in the generation or the amplification process of thrombin that allows us to make a clot. We know that factor 10 is integral too because it's also been the target of many of our anticoagulants that have been produced to warfarin therapy. So we know that factor 10 is very important, and if you're deficient in factor 10, factor 10 is in fact a form of an inherited rare bleeding disorder, and we now know that we've identified the factor 10 gene in the 1980s. There are a number of mutations that lead to people either having a heterozygous or a homozygous variant form of the disease. Heterozygous form is not always associated with bleeding, but it can be, and we're learning more about that. But certainly the homozygous state can be associated with severe bleeding. UCL genetic database has shown over 180 unique variants that exist. Most of these are point mutations. But we're learning more and more about the genotype and phenotype that goes along with factor 10 mutations. We used to think perhaps certain ones were associated with more severe bleeding, but I don't think we've made such strong associations now. So factor 10 deficiency is an ultra-rare bleeding disorder. We think it has a prevalence of about 1 in a million. In fact, there's increasing data coming out of the UK and from other groups that suggest that perhaps the prevalence is a bit more common than that. Perhaps people that might be in the range of 1 in 200,000. You can see in the graph on the right there that that's the cumulative reporting from the World Federation of Hemophilia Annual Global Survey. And I've circled at the very end there for 2023 the factor 10 deficient patients in the dark blue, and you can appreciate that really they make up probably over 3% of all the inherited bleeding disorders that are reported. Certainly is the next commonest after factor 7 and factor 11 deficiency. So it's a group of patients that deserve some more attention. In India, you also, of course, contribute to the World Federation Hemophilia Annual Global Survey, and in 2023 you had 67 factor 10 deficient patients. But as we've already described, I think in some previous talks, this is probably under-recognised, and indeed it's probably something in the range of 20 times that in terms of the population living with factor 10 deficiency. So if you have factor 10 deficiency, what does it mean? Well, generally we've got data from several groups that have described quite nicely that a lot of these patients will bleed. These patients can have a range of bleeding, the severity of which will range from severe, such as intracranial bleeds or gastrointestinal bleeds, right through to much more milder symptoms such as epistaxis, percutaneous bleeds. But many women with factor 10 deficiency, for example, can suffer from very severe menorrhagia. Rarely, certainly in some of the patients that I've been helping, patients can present with musculoskeletal bleeds, not unlike severe hemophilia A or B. And I think with that I want to share with you a patient journey to help us understand situations of a factor 10 deficient patient. This is a woman I've been helping for over 15 years. She's 48 years old, she's a school teacher. She's had a long history of mucocutaneous bleeding, through epistaxis, gingival bleeding, and very heavy periods. Aside from that, she's also suffered from musculoskeletal bleeds. So she's quite an active person, and at some point in her adolescence and early 20s, she wanted to become a surfer, and as a result of that, she used to get recurrent bleeds into her elbow. So her elbow bleeds and thigh bleeds, calf bleeds were all musculoskeletal bleeds as a result of not having sufficient factor 10. When I look back at her history, she'd actually been exposed to transfusion transmitted infection from previous plasma products to try and manage these bleeds. We treated her for a hepatitis C. When I looked back at her original diagnostics, I could see that she had prolonged coagulation screen, as you'd expect, both the intrinsic and extrinsic parts. Factor 10 level was undetectable at less than 1. Gene analysis confirmed that she indeed had multiple gene aberrations. This included a 17 base pair deletion, which resulted in a premature stop codon, and that would easily explain why she didn't have any circulating factor 10. Further family studies showed that her father actually was a heterozygote, so he had one of the mutations and actually a reduced level of factor 10 at about 37. As hemophilia A or B. We know that with hemophilia A we think about severe as those with undetectable levels, and then we talk about moderates as those with 1 to 4, and then above 5 to 40 is the mild. But from the rare bleeding disorder database and from several other groups, we're getting the impression that certainly we need to have different thresholds in some of our rare bleeding disorders. Correlate quite well with the likelihood of bleeding. But the severity really seems to be at anything below about a level of 10. People with levels of 10 or less are at a high risk of major spontaneous bleeding. So we really need to think about different thresholds for our categories of how we describe our patients. And that also, of course, translates to thinking about what our targets should be when we're trying to treat them and improve their quality of life. Back to my patient. So as I mentioned, she had recurrent musculoskeletal bleed. She ended up with early onset arthropathy involving her left elbow. Some radiographs show quite nicely there some degenerative change around her elbow. She actually required a radiosynovectomy, but has limited range of movement at that elbow long-standing. So what are the treatment options that we can consider for people who don't have enough circulating factor 10? Obviously, for minor bleeds, we can try and manage things locally. We can manage with antifibrinolytic agents such as tranexamic acid, fibrin glues, but really, in the case, we have to consider replacing with factor 10. In the past, we've used fresh frozen plasma for that. In the UK, we've been using prothrombin complex concentrate up until the availability of a new factor 10 high purity plasmate called Coagidex. In fact, Coagidex has been approved by the FDA since 2015, approved by the EMA 2016, and I think available in India since the beginning of last year. It's a plasma-derived human blood coagulation concentrate that is manufactured in the UK from US-sourced plasma. It is indicated for the treatment and prophylaxis of bleeding episodes, for the treatment and perioperative management of patients with hereditary factor 10 deficiency. I'll come back to my case. Again, menorrhagia was one of the big issues for this school teacher. She was suffering a lot with quite a long duration of menstrual periods, and although she tried hormonal therapy, she tried regular tranexamic acid, this was still not preventing her from getting iron deficiency. She was intolerant of oral iron, so you can imagine that it really was becoming quite a big issue for her from day-to-day life. She was having intravenous iron maintenance to try and maintain her iron levels, but really when we started regular factor 10 replacement, that's when it made a significant difference to her quality of life. Whilst she had prothrombin complex concentrate in the past, she was not using that nearly as regularly. So once we had access to Coagidex, a plasma-derived factor 10 concentrate, she was able to use that frequently to try and control things, and we were also able to start thinking about doing PK parameters and measuring a factor 10 to see what we were achieving and trying to correlate that with her clinical outcome. And you can see in the graph there that there's several levels around 5 to 10 in an otherwise she had undetectable levels before, and also you can see they've also got some peaks in there showing that we were achieving peak levels of factor 10 of around 40. This is an example of our treatment diary that we ask our patients to complete in the UK, and you can see that she was using Coagidex 2,000 units every 4 to 5 days regularly, and the treatment burden using the concentrate was so much less than the PCC that she was otherwise using previously. What evidence base do we have for suggesting that she should be on prophylaxis? We have a very comprehensive clinical trial program. This is shown here in the programs called the 10 studies, and the initial pre-registration study was 1001, and that was a comprehensive international multi-centered prospective study looking at safety, efficacy and tolerability of Coagidex in patients with hereditary factor 10 deficiency. But as well as that, the program extended to look at prophylaxis in the surgical setting and also to look at special groups. And so data analysis subsequently after those studies has looked particularly at women and girls and also the pediatric population. How efficacious was it in controlling bleeding? The 1001 study showed very well that bleed control was excellent for the vast majority of patients administered Coagidex. And in the surgical arms, we also showed that it was excellent in terms of providing hemostasis support for the surgery. If you just look at that table to the right-hand side, you can appreciate that the surgical settings in which Coagidex was used in the clinical trial range from very mild procedures, minor procedures like dental work, right through to major procedures, orthopedic operations, and even a coronary artery bypass graft. So I think we've got good evidence to support its use in efficacy to control bleeding and to prevent bleeding. Another interesting thing is that when we looked at post hoc analysis of the data that we had on the Coagidex clinical development program, it's evident that, like many other clotting factor concentrates, children handle it slightly differently. In vitro recovery was lower in our neonates and our young children. The clearance was quicker. So the realization that in the young population, we certainly would need to consider higher dosing. Turn to my case again that I've been sharing with you. So she was maintained on prophylaxis with Coagidex, and that prevented her from having significant musculoskeletal bleeding, and it also helped her to control her menorrhagia. She came to me and suggested that she wanted to start a family. She was going for IVF. Indeed, she enrolled in IVF privately. This meant that we had to consider how to help her with an egg collection, which we covered with factor 10 replacement. Unfortunately, whilst there was no complications from that egg collection, there was, her IVF cycles were subsequently unsuccessful. Subsequently, she actually did fall pregnant spontaneously. So she spontaneously conceived after failing IVF cycles. And so we then had to think about what to do about factor replacement through pregnancy. Again, this is an issue where we don't know much about it, largely because we're dealing with a rare bleeding disorder in the context of pregnancy. We elected to do a bit more regular PK monitoring and try and maintain her troughs at least 5. As she got closer to delivery, we increased those levels of factor replacement so that we could aim to get her up to a peak of 40 at the time of delivery. And so you can see that she delivered essentially about 4 years ago, in which we were having levels between 40 and 70 to help her through the delivery, successful with minimal blood loss. We elected not to give her thromboprophylaxis, even though she was at an age where one would normally consider that in the obstetric setting. I think it's important to consider clearly how we manage these women with rare bleeding disorders is unclear to date, and the most important thing is probably that we manage in a tertiary referral centre with a multidisciplinary team in which we have close communication with the obstetrics team, the anaesthetists, and of course the physicians. And we know from anecdotal evidence and reports that there are bleeding complications are higher in patients with factor 10 deficiency. We know that there are issues with preterm delivery and indeed fetal loss and miscarriage. It's probably suggested that we should be doing increased surveillance through the pregnancy as well to look out for things like subchorionic hematomas or other placental hemorrhagic complications. For delivery, I'd suggest that we must give factor 10 replacement, as we did in the case of my patient, that we should be aiming to have all factor levels above 30 to help support the surgical delivery. So I know I've gone quite fast, but I wanted to share with you the patient journey, and I think one of the most important points I want to make is that 10 deficient patients can bleed, and they can bleed quite significantly. We need to consider providing prophylaxis for many of those patients, and we now have Coagidex, a new treatment option for them. I think that we have to individualise the therapy based on the types of bleeding these patients suffer from, including whether it's spontaneous or provoked bleeding, how frequently it is. In terms of what target levels we aim for, I think if it's for prophylaxis, we should be aiming for a level of 5 to 10. Trying to get those patients out of what is probably the severer group of deficiency. In surgery, we obviously need to aim for higher targets, peaking probably up to 70, but then keeping those levels around 50 for the first 24 to 48 hours after surgery. I made the point that in the very small group of people, in the neonates, age-related levels are important to consider, and certainly also the fact that the recovery much lower, and therefore they may need more increased dosing. This slide just shows the sort of doses that we use when we're using Coagadex. I think you can appreciate that if we're treating events, we suggest using 25 units per kilo in adults, up to 30 units in younger children. And for bleeding prophylaxis, to prevent bleeding, we use a similar dose range of 25. But in the pediatric population, we might need to go up to a dose of around 40 units per kilo. Again, for surgery, we don't have clear-cut guidance, and the most important thing is that you're doing regular measuring of your factor 10 levels. So, factor 10 deficiency is a severe, rare bleeding disorder. Patients are heterogeneous in terms of how they might manifest those bleeding symptoms. Some will have GI bleeding, others intracranial bleeds. Menorrhagia is very common in women. So there is a large proportion of our factor 10 deficient patients who need prophylaxis in order to improve their quality of life. Coagadex is now available in many parts of the world, and certainly now in India, and it's a versatile high purity factor 10 concentrate that should really be a first-line treatment option for those who are suffering from factor 10 deficiency. The precise targets that we should be aiming for in prophylaxis are probably levels of around 5 to 10. Certainly in surgery those levels have to be much higher, but both those statements need to be qualified by understanding that you have to tailor it to the individual. That a lot of this is expert driven and lacks a strong evidence base, but with the use of Coagadex we may be able to get a better understanding of what our precise target should be in our patient group. Thank you very much for your attention.
Thank you, Dr. Austin. I would like to request Dr. Austin to please remain on the dais. I would like to ask Mr. KVS Prasad, DC member, the Federation of India, to kindly felicitate Dr. Austin.
What you're saying, Alok, yes, and thank you for that. I think illustrate the point precisely with what I was saying, and that is that we have to tailor the therapy to the individuals, and I think also we have to have laboratories that are accurately being able to monitor the factor 10. But I agree that there will be situations where we do not need to go up above that, but I think there are also some major surgeries where we might have to consider that. And again, it depends on the type of surgery and the patient affected. Questions?
Dr. Austin. Thank you, Dr. Austin. Next up, I have a very important notification to give everyone. Check out your rooms. Kindly check out all of your rooms. Now we are going to break for lunch, so please check out from your rooms, have lunch, and please join us back post lunch for more interesting sessions. Thank you.
lunch is being served out. A launch of a book. Hello. So, there has been a surprise with this. This is not planned, not expected. Uh, we have designed an awareness book. Awareness is the most important element of hemophilia care. We have had two beautiful, wonderful volunteers from especially RC. Can you join me? So today on World Hemophilia Day, we would like to launch an awareness book both in Hindi and English. So I would request to everyone to please get down from Much, Madanji and Rajasthan team and Andhra, thank you so much. Again, I would like to thank both Niranjan and Nancy for contributing to this book, and I would request them to join us in launching of this book, please.
हेलो भाई हेलो भैया कुछ बोल रहे थे
I would like to kindly request everybody to come back and have your seats because we are going to start our next session. Please have your seat so we can get started with our next session. We're now going to go ahead with our next session, which is multidisciplinary care. And for the first presentation, we have life and challenges faced by people with hemophilia and need of comprehensive care for quality of life by Dr. Venkatesh Parlikar, ESIC, Kolhapur.
Good afternoon all. First of all, thank you HFI for giving me opportunity to speak with the esteemed crowd here. So my talk is about the challenges faced by a person with hemophilia across the lifespan. So I will take you through small journey of PWH, their lives, and what are the challenges they face at the different ages, and what is the solution towards the end. So here's a quote. It says, "A bird sitting on a tree is never afraid of the branch breaking because her trust is not in the branch but on its own wings." But in case of hemophilia, what if the bird can't trust his own wings? Because a PWH always has a fear that he may have a bleed at any time, and that is why it's difficult for him to live with that fear. Although he has all the capacity to live a normal life to contribute to the growth of the country, but still he has a fear in his mind. So this talk is not only about challenges with hemophilia, it's about courageous stories of people living with hemophilia. So starting with the first thing, I'm telling you a story of a family. The index case name is Krishna Kant, who had repeated joint bleeds from his childhood. He used to walk with crutches for most of his life due to the joint damage. Eventually, he died with a major gastrointestinal bleed some 25 to 30 years back. This is a scenario when we didn't have treatment availability in India, neither in diagnosis or the treatment. So what is the crux here? Krishna Kant was never diagnosed with the lab diagnosis of hemophilia. This marks our first challenge. So first challenge we face with hemophilia is the delayed diagnosis. Because we have done a survey in 2023, so where we found that 34% of children were diagnosed after 1 year of age with hemophilia and 15% after 5 years of age. That is a significant delay. When we are talking about the prophylaxis, we are saying that we are starting with the primary prophylaxis, where we start the prophylaxis before any joint damage can occur. So if we are diagnosing him after 5 years of life, it suggests that we are already delayed. So this is the first challenge. Next thing, this is the story of a family with many phases of hemophilia. So Krishna Kant had 3 daughters, Suman, Pushpalata and Sandhya. So his first elder daughter, Suman, had a son whose name was Satya. So Satya was diagnosed delayed with the hemophilia. He had both knee arthropathy, significant limitation in the mobility. Despite that, as I said, this is the story of courageous people with hemophilia. Despite all the mobility, staying in the periphery of Maharashtra, he started his own printing firm. He was doing well. But one day he had IC bleed. He was staying in Yavatmal. From there, he couldn't get referral earlier. He didn't receive factor and got referred. Before he could reach the hospital, he died on the way. So this story tells us the unfolding burden and field challenges. So challenges are, one is we have repeated joint bleeds causing disability. Next is the mortality associated with hemophilia due to IC bleed or GI bleed. Next is unavailability of the factors, which is the concerning thing for hemophilia patients. Next is unavailability of the expert neurosurgeon or a person who is confident enough to manage a case of hemophilia with support of a hematologist or a physician. Next, we need to train the people that in a referral center, like it's not like that we can have a neurosurgeon in all the setup. So the person who is catering for hemophilia in a primary healthcare center should be sensitized enough to give factor in transfusion and then should refer the patients. So these are the challenges that we have. So the data suggests that around 20% mortality in hemophilia is due to IC bleed, that is in the developed countries. So where prophylaxis is a common thing. The data suggests the number goes up to 44.3% if you go by the Indian data. This is study done by Dr. Cecil sir. It suggests 44% mortality due to IC bleed followed by the trauma and gastrointestinal bleeds. So next thing, we are coming to the next challenge. We are continuing with the story of the family. From Suman, the second daughter is Pushpalaka. She had one son and daughter, Rani. So Ashish was her son who was diagnosed with hemophilia at 2 years of age. So he was diagnosed with phimosis at 3 years of age requiring surgery. But as I said, the need of surgery, again unavailability of the confidant and support or the factor or the hematologist or physician. Because of that, he had to refer to Mumbai where he got operated. Again, at the age of 14 years, he developed hematuria, which was due to renal calculus. He had to stay like 700 kilometers from his place for 2 weeks, losing his family's earning. Eventually, as I said, the courageous people of hemophilia, he graduated, he did post-graduation in IIT Mumbai, and now he is living happily married life. So this marks the need of surgical care. There's a data suggests that the most common surgical issues which hemophiliac face is the orthopedic, then head and neck surgeries, abdominal surgeries. So to perform all this surgery, first we need a tertiary care center. Next, where we have a confident hematologist. Next is availability of factors and confident surgical hands. So we are going forward. The sister of Ashish, Rani, she got married. She had a son whose name was Prem. On his first immunization, he developed thigh hematoma. So hematoma with the history of hemophilia in maternal uncle, despite that they were not aware there is a thing called carrier detection or prenatal diagnosis. When her husband got to know this, the marriage was going to break. What happened? He was feeling he was cheated. The father of the child said, we could have done the carrier detection, we could have done the prenatal diagnosis, and we could have avoided the thing. Eventually, with the counseling, the things got settled. They planned for the second baby, and with the prenatal diagnosis, it came negative for hemophilia, and they have a second son. Prem is doing masters in physiotherapy from Nagpur. So this marks the challenge with the lack of awareness and availability of carrier detection and prenatal diagnosis. First thing, we need a trained personal experts in the field, which is a complicated thing for the genetic diagnosis. But important thing is to highlight the need of carrier detection among people with hemophilia. As we did the survey, we found that only 20% PWS said that their sisters have been tested for carrier. Most of the thing when we speak to Dr. Bipin sir, we come to know that carrier detection was not done. The female was brought once she was pregnant. So it delays the diagnosis. First they have to do the carrier detection and then they have to do the prenatal diagnosis. So it is important to address the need of carrier detection and prenatal testing. So Krishnakant's third daughter, she's Sandhya, she had 2 boys. One is one was with moderate hemophilia. At 4 years of age, he underwent a dental procedure where he bled profusely. And without factor coverage, the procedure was done due to lack of awareness about hemophilia. Then he was admitted, he was treated with factors and required hospital stay for 4 days. But eventually he overcame the thing. He is moderate hemophilia, so he has passed his pharmacy and he is running his own medical store. So this marks another component, another expert need in the care of hemophilia, which is dentistry, which highlights the role of dentist in hemophilia care. As per the study done from the dentist about hemophilia, they found that incidence of bleeding, like they had done interventions, where they found incidence of bleeding with tooth extraction was 12% around, and intervention with 12% and tooth extraction was 8%. So, and another thing they noticed is that the delayed bleeding is the most common complication. The bleeding doesn't happen immediately after the tooth extraction. It usually starts after 3 to 5 days of the extraction. Next, we are coming to the her younger son, Ravi, who was diagnosed with severe hemophilia. He developed calf hematoma at the age of 18 years due to delay in receiving factors. If they received factor, and they felt that if they have received the factor, the swelling will subside, there is no need to do anything. They spent almost 5 to 6 months at their hometown without doing anything. This delay caused development of the contractures in the calf, eventually causing equinovarus disability, deformity, and it needed surgical correction. So surgery was done. Later he has become a doctor. So this highlights the need of orthopedic surgery and physiotherapy, because earlier, after taking the factor, had he received proper physiotherapy, he wouldn't have developed disability. So that could have prevented disability. So that is the importance of physiotherapy in hemophilia. So if we look at the age graph, so we can see that at the neonatal age, first thing is delayed diagnosis. They develop muscle bleeds after immunization. Next is the easy bruising, joint bleeds, like many communities undergoes circumcision, which cause delayed healing, prolonged bleeding, delayed diagnosis. These are the issues in the neonatal age. When the child grows, he becomes a toddler or school aging child. They again grows with the activity of the child. There is increase in the incidence of joint bleeds, dental issues, and that age is common for diagnosis of phimosis, hernias, and one of the important thing of the childhood is the play, which is taken away by hemophilia. They have restricted play. When this child grows up and become an adolescent, he has low self-esteem because he has been isolated in all the activities in his childhood for most of the life. With the changing in the care and availability of the treatment, this scenario is changing, but still we can say that there is low self-esteem among the adolescent with hemophilia. They have poor scholastic performance due to joint bleeds and school absenteeism. And it is important to know that till now they were treated in a few pediatric care. So transition from pediatric to adult care is one of the important things. So pediatric, they are treated like the parents because there is low patient load. But when it comes to adults, there is high patient load. The doctors can't give that much time and care to the patient in adult care. So that is one of the things we have to highlight in the transition of hemophilia care. When this child goes up, become a young adult, that age is common for joint disabilities, because over the period of the time, if he doesn't take proper treatment, he will develop joint disabilities, causing earlier joint replacement in the younger age, which is common in 60s plus. Hemophilia, it comes at 35 to 40 years of age. Next is trauma, accident with the activity, transfusion transmitted infections, which has gone down with the advancement in the treatments, issue in employment and marriage. These are the personal issues faced by hemophiliacs throughout their lives. And when this child, a young adult, goes into the geriatric age, the most common things are non-communicable diseases, hypertension, diabetes, dyslipidemias, and they have the joint problem, and that restricts their activity, which causes obesity, and the vicious cycle continues. With obesity, they have diabetes, hypertension, and the cycle continues. And chronic pain with the joint issues. And another thing is, with the growing age, they may need surgical interventions, and it again causes difficulty to do surgery. So the gist of the talk is that I'm just highlighting the challenges. I'm not giving the solution. So if we look at the slide, we can see that PWH is at the center. When we are talking about hemophilia care, multidisciplinary approach, PWH is at the center, who is in a close proximity to his treating hematologist, physician, or pediatrician. But hematologist himself can't treat the patient because it's a holistic approach, multidisciplinary approach. We need support from orthopedic surgeon, physiotherapist, general surgeon, neurosurgeon, pathologist, and dentist. And so this is the core need of hemophilia care. So if we give, we have all the people working together, we can save PWH from morbidity and mortality associated with hemophilia. So as I said, this is a story of courageous people with hemophilia. This is what courage looks like if we give adequate and timely comprehensive hemophilia care. You can see many of the people, they have all been successful in their life, in their professions, and also contributing to the hemophilia community. So if we give adequate, like most of them have undergone surgeries, transfusions, infusions, everything, and still they have become successful. So my message is, if the bird doesn't have confidence in himself to fly, if we give him confidence that you try and we will help you out, we will catch you if you have any issues. So there will be more photos in the slide with the courageous people with hemophilia. Thank you so much, and this highlights the need of multidisciplinary care in hemophilia. Thank you.
Dr. Venkatesh. I would request Dr. Venkatesh to please join us on stage for a second. I would like to request Mr. Dinesh Bhai Vadadia, member, Hemophilia Federation of India, to felicitate Dr. Venkatesh. Not sure if I saw it, but your photo also belongs on the last slide of heroes. Very good job, Venkatesh. Thank you so much. Very proud. Next up, we have a panel discussion on multidisciplinary comprehensive hemophilia care, and this will be chaired by Dr. Meera V. I would like to welcome Dr. Meera V to the podium, please.
Bosses of the various states how much factor we get and where the budget goes to the allocation for the various other policy decisions. So this is a very important aspect in hemophilia care. In fact, it is the starting point where it all starts. No matter how much we deliberate to improve the access to care and all that, if there is no budget and if they are not planned properly, the PIP doesn't go right, approvals don't happen in time. I'd like to invite on stage the various stakeholders from various states who are part of this panel. Dr. Mahendra Kendre from the Government of Maharashtra, Dr. Nirmal Chandra Mandal from Government of West Bengal, Dr. Sahi from Government of Jharkhand, Dr. Girish Sharma from Himachal Pradesh, Dr. Shanti from Tamil Nadu, and Professor Goswami from West Bengal.
Dr. Girish Kumar from Himachal Pradesh. Nodal officer.
Dr. Mahendra Kendre, Assistant Director, State Blood Cell, NHM Mumbai.
SI, DIC, Jharkhand.
NHM Chennai.
Dr. Nirmal Chandra Mandal, State Nodal Officer, Government of West Bengal. Krishna Goswami from North Bengal Medical College, the control unit, and also looking after hemophilia.
You all know the hemophilia care system in the government has come a long way, way back from 2005 when it first started in the state of Karnataka. Just like we had a talk in the morning about the unmet needs and the state blood cell which was created in every state in 2017. From then on, every year, the streamlining of the healthcare system has been happening. Like there have been innovations and living up to the unmet needs, I think the government system is also trying to innovate itself and themselves and trying to meet the challenges faced by the hemophilia patients. Whereas it is much more simpler to do it in the research and marketing levels, whereas doing it in the government is even more challenging, which not many of them will be aware. So today we'll try to understand what are the challenges and what are your success stories. First, let us begin with the positive success stories. So, can all of you elaborate on what is your best practices been for establishing and even more importantly,
In Himachal Pradesh, we have that is a new college and we are important part here is the access of our STC. All our we are in a process of building the same in other medical colleges. All the six medical colleges, we are actually in the they are established.
do you have a separate physical center or has it been, functional HCC?
We are in the process
स्पेशलाइजेशन का एज है, लेवल पर सुपर स्पेशलाइजेशन की आवश्यकता हम लोग महसूस कर रहे हैं। जो हम मेडिकल कॉलेज लेवल में ही सुपर स्पेशलिस्ट की सुविधाएँ
actually in all of we have about 32 medical colleges in the training is vital and it has to be periodical because it has frequent announcements.
registered 84. Two nodal center, there is and also in Northern Medical. Unit, that is treated with to the on-demand part. Methodology. So we are getting what are the resources or what are the diagnostics, what are the management part, what we are getting. This is one very important issue.
the supply of the factor. We have arranged plasma derived from the Reliance. They are not properly supplied.
As we understand, there's a primary care level where, basic bleeds like joint bleeds or early muscle bleeds. A tertiary care where they should be able to treat intracranial bleeds. How have you integrated these three levels of care? What is the referral system?
So that was actually allotted to these integrated centers, 10 districts. We found that the compliance was poor because even traveling about 30 to 40 kilometers is a problem twice a week. So now we are identifying to the blocks, nearest blocks. We are planning to,
can procure the factory clinic. Also approved. Our higher officers.
Question was because you already mentioned. Since the NHM is now is your opinion about this, and if you don't agree with it,
West Bengal, we have 89, and we have average component blood component 740.
No, the
We have
challenge is
already there arrangement of treatment at district level sub-division hospital. In nodal center, the Kolkata Medical College, NRS, all facilities are there.
the NRS may not get. That is the challenge.
There is every facilities, physiotherapy support, arrangement of factors.
Shanti wants to.
The main issue is the usage amount.
In conducting surgeries in hemophilia. Emergency surgeries. How many of your don't do any musculoskeletal surgery for which the patient has to go to the So from the concept of having integrated hemophilia your idea about the role, how far of standards of hemophilia care? Do you think you should have more of them? And
Comprehensive daycare center should be the final solution for the daycare center. We have started only daycare center to infuse the patient right now. The new centers 27, but our old 7 center have dedicated manpower, and we are giving physiotherapy. We are doing the lab test. We are doing the counseling of these patients. But we have to upgrade the new centers. We have proposed manpower for that, but it is not up to our throat. So we have given the training to the existing manpower, and we have trained. But issues are they are transferred from one place to another place, one department to another department. So we will try for the same that the trained manpower should be at least for 4 5 years at that place, and for that purpose. That is the
main challenge,
yes.
that they don't stay in one place. You put in all the effort, you train them, and then they are just displaced.
They are transferable. So it is one of the issue.
Madam?
Definitely help these patients because everything is available under one roof. Our CNCHS program, we are able to.
So what is the challenges that you face in Bengal? You have ICHS.
We have established dedicated comprehensive care in all 36 centers. Also, factor assay is not in all centers. NRS and Kolkata Medical College Hospital, they have the arrangement of factor assay. Few centers are the factor assay, inhibitor assay, but all other centers are not possible to do that.
So Dr. Kendra, apart from this, is there any other challenges that you
We have a dedicated team at NRS Medical for the dedicated for the
how many of you have been able to establish a genetic testing center unit in your states? I know in Maharashtra the IH is there, but apart from that, for the, keeping this program in mind, any of you have been able to add?
To do the prenatal diagnostic procedures.
This has been part of the government DBT Nitan Kendras or the Tamil Nadu government has
No,
established?
this is the Tamil Nadu government, and
Okay.
Institute of Child Health has been recognized by the central government as a center of excellence for genetic.
They have genetic testing unit there?
We actually do not hemophilia, but we are doing it for sickle cell and thalassemia.
Diagnosis is offered?
Prenatal diagnosis we are offering, and but only thing is till now this tests are outsourced. We got fund from the NHM for this program. Right now the sickle they can confidently do for the fetus in the amniotic fluid. They have some more machines which they need. So right now these are outsourcing.
Two centers, Kolkata Medical College and NRS. We have a genetic lab, molecular biology, positive data sampling are all there.
That's great. So is there anything else that which the challenges you face as administrators that you would like to share and deliberate upon?
In Maharashtra, it is a very wide and best infrastructure. for HPLC testing in first trimester.
Regarding the challenges, the most important challenges for us is the procurement of medicine that always remain there. And second challenge of manpower and specialty. Like we have only one hematology that is based on the IHC. So these are the main challenges. And apart from that, to establishing the new comprehensive treatment centers that is in the pipeline. So they are the big challenges which we are facing.
So how are you all facing the challenge of factor VIII not availability?
So that always remains. It's always there. There's always shortage. Sometimes there is a supply problem. Sometimes there is not coming, tendering problems, and always that is one main issue which always remains. Factor IX is a critical condition that is nowadays for last few months nobody is flying. I talked to the other public health head also that we have very huge shortage of factor IX also. These are the challenges we face.
Anybody would like to add anything more?
And which challenges previously regarding the funds. We are trying to get funds, maximum funds. But since last 1.5 years, we have funds, but we are not able to provide the factors at the end of the provider that will not provide the factors in time. Their capacity is not, I think their capacity is not quantity of factors. And the previous players are also not participating in the tender. In last tender, one of the company have participated, and at the last moment, they withdrawn from the tender. So this is happened in the last year only. Previously, we are getting the smooth supply of the factors, but since last 1-2 years, they have introduced new factors. So I think they want to procure these factors only, and they stop the procurement of the previous factors. I think so.
I think this discussion will never end, but for want of time, we'll stop here and thank you all. Yeah.
Without challenge, we can't progress. So definitely, all of you are doing very well at the your level. But still, I want to say something, sir. Maharashtra is one of the leading states. It always show the path to the other states. But still, sir, मुझे सब हो रहा है, फंड है, सब कुछ है, कोई भी पेशेंट रो रहे हैं सर। सडनली ISTP जैसे जो मेन सेंटर जो है जो WFA से अप्रूव हो कहाँ जाएंगे पेशेंट इमरजेंसी में क्या करेंगे क्या सिचुएशन खड़ा हो जाएंगे अभी मेडिकल कॉलेज का बजट सैंक्शन करने में डेफिनेटली टाइम जाने वाला है तो क्या वहाँ फैक्टर नहीं मिलना चाहिए और दूसरी बात सर अगर सब हो रहा है कुछ कंपनी ऐसा हमें समझ में आ रहा है कि वो कंपनी का कुछ ठीक है कुछ प्रॉब्लम्स है आपके साइड से डेफिनेटली नहीं है हमारे इधर क्या कभी हफ्ते में गया हफ्ते से फिर DHS में आ गया इधर से उधर बॉन्ड फेंका जा रहा है फार्मा कंपनी भी प्रॉब्लम टेंडरिंग सॉल्व कर दिया लेकिन ऐसा ही प्रेशर शायद आपके ऊपर भी हो सकता है अगर है सर इस सिस्टम को रियली चाहते हैं कि कुछ करें हमें भी बहुत सारे रूरल एरिया के जो पेशेंट जो पहले से जो लोगों ने जो सब कुछ आज तक किया है
जो सिचुएशन बोला वो करेक्ट है। प्रॉब्लम नहीं है। जो प्रोक्योरमेंट एजेंसी है नहीं, तो इसमें फंड का कुछ इश्यू नहीं है। तो आपके माध्यम से आप ट्राई कर सकते हो कि मैक्सिमम कंपनीज इसमें पार्टिसिपेट करें और मैक्सिमम फैक्टर हमको पैसा मिलेगा। तो उसके लिए हम ट्राई कर सकते हैं, लेकिन फंड का आज की डेट में इश्यू नहीं है।
जो है दूसरे देश पर डिपेंड रहते हैं और दूसरे देश में फार्मास्यूटिकल कंपनी जो है रिसर्च करती है, नया प्रोडक्ट निकालती है, की तरफ जो है अपने को देखते हैं कि वो हमको देगा। हमारे देश में जो है रिसर्च सिस्टम को बढ़ाने की ज़रूरत है। एजुकेशन सिस्टम जितना है सबको अपग्रेड करने की ज़रूरत है। चाइना हम लोगों से कितना आगे निकल गया। पूरे विश्व का जो है सारा प्रोडक्शन का 70% 60% वही करता है। बेसिक लेवल पर जो पॉलिसी है हाई लेवल पर अपनाने की ज़रूरत है। और जब तक ये सब हम दूसरे देश पर निर्भर रहेंगे, हमको लगता है कि ईसीजी मशीन हम हिंदुस्तान में पैदा नहीं कर सकते हैं। अल्ट्रासाउंड और सब जो दूर दूर की बात है, बल्ब भी शायद हम बाहर से ही पार्ट्स उसका मंगाते हैं। मेजर चैलेंज यही है।
Help the hemophilia community balance both when we
I would like to thank all the panelists and special thanks to Dr. Meera for chairing this amazing panel discussion. I would like to ask all the delegates to kindly be on stage so we can felicitate everyone. I would like to bring up on stage Mr. Balshiram, RCC West, Hemophilia Federation of India, to felicitate the delegates. I would like to invite Balshiram sir to felicitate Dr. Meera B. Dr. Mahendra Kendre. Balshiram sir. Dr. Mahendra Kendre. Dr. Nimai Chandra Mandal. Dr. S.N. Sahi. Dr. Girish Sharma. Dr. Shanti. And Dr. Vidyut Krishna Goswami. Thank you all for that wonderful session. Our next session is, our next topic is ICMR initiatives and HTA, Health Technology Assessment in India, Applications Towards Hemophilia Care Delivery, by Dr. Kavita Rajashekar and Dr. Hina Tabasam.
Have been actively supporting research in various health issues that includes hemoglobinopathies. So I'll be talking about a brief on what initiatives we have taken on in so, apart from that, since yesterday there have been a lot of discussions, and as we quality of life and complications if untreated. Right now, factor prophylaxis is the standard treatment, but it does faces challenges for adherence and limited access to higher dose regimens in resource limited settings. Flexible dosing and improved adherence, and there are trials showing reduced bleeding episodes. So I'll come back to the discussion. So plays a significant role in advancing hemophilia care in India. Its research and management we have been delving in areas from diagnostics, includes and training and management as well. Focus area, if to be very brief, if I may. So when I talk about improving diagnosis and treatment, so we have been involved in development of guidelines for hemophilia care, promoting prophylactic treatment. We are working towards ensuring access to safe and effective clotting factor concentrates. One of our mandate is also to strengthen capacity, so capacity building and training. So we do provide training on hemophilia diagnosis, treatment and management, and one of our goals also include awareness about this particular health condition. When I go to our primary mandate is to support research and development. So there are studies going on studying the prevalence and incidences of hemophilia, developing new treatment protocols, and this is both being done extramurally, that is by non-ICMR institute, as well as the intramural, that is our own institutes. through various schemes of funding and evaluating the effectiveness of existing interventions in the field. So, under Research and Management Initiative, ICMR has established a Center for Research Management and Control of Hemoglobinopathies at Chandrapur, Maharashtra. So, this is a high state-of-art institute which is equipped with advanced laboratory facilities that includes high-resolution spectrophotometers, fully automated clinical chemistry analyzers, and the tests for diagnosing and managing hemophilia such as G6PD clotting factor analysis are being carried out this institute. Apart from that, we also have institute in Mumbai, National Institute of Immunohematology. They are also focusing in hemophilia research. And apart from that, ICMR collaborates as a cost effectiveness analysis of emicizumab prophylaxis in patient with hemophilia and Lexis in patient with hemophilia in India and this infers its relevance to Indian 69 for emicizumab compared against HDP among hemophilia cost as the primary driver of ICR values highlights the need for price reduction for broader so this is the key findings of this particular study which has been published. So we can share the link if anyone is interested in the same. We also are involved in drafting and dissemination of guidelines and guidance documents on various health conditions. So we have also and clinical trials in the year 2019 under revision as of now, and we have also run task force on various health conditions which are aware about the challenges and so we aim to address the gaps, ensuring access to people to promote awareness in this particular health condition, and we also advocate towards the existing current policy changes to support hemophilia care. Thank you so much. I have given limited information on the HT analysis because my colleague Dr. Kavita is not able to join today, but we are happy to be available for any query through our phone numbers and emails. Thank you so much.
Thank you, Doctor, for the wonderful presentation. So now I would like to invite Mr. Premrup Alva, President, Hemophilia Federation of India, to kindly felicitate the guest as well as Hemophilia Federation India to felicitate.
Dr. Vijay Kumar from So as you all settle down, the importance of prophylaxis was emphasized in the third edition of the World Federation Guidelines and re-emphasized in the Hemophilia Guide. We don't want to argue whether prophylaxis is needed or not needed. What we want to discuss today in this panel are two aspects. How is this recommendation getting implemented in different states and the policy of that state or territory? how are we able to operationalize it in terms of procuring products and offering it to patients. So these are two critical aspects. So we can start at any end, take 2 or 3 minutes to give your situation. We all accept prophylaxis is needed. Does the state or territory policy allow it? Then we'll come back to the products issue next. First the policy, then the products. We want prophylaxis. So baby gets more milk. To also make the baby gets more milk. To also make the government realize it's not some fancy idea of Dr. Bilal. Also understand and must seek and demand. We should think about that.
Get prophylaxis or who will have get prophylaxis.
So, Dr. Bilal used a very nice term and I should have used that, regular replacement. So what you are saying is, in Rajasthan you can offer regular replacement prescribed, no problem.
No written policy like that, who will get, who will not get. It's on the physician and on the patients. Main issue in Rajasthan is that patients are not getting prophylaxis, they are not coming.
Very glad you mentioned that because this has happened internationally also. The first year when Brazil shifted from episodic to prophylaxis and bought 3 IU per capita for the country, more than 50% of the drugs were wasted for treatment. Policy and implementation, possible demand has to be created, and here specifically stopping it. Three So is there a gazette or is there a notification or?
It is a notification, and with the help of hematologists and those people who are involved in the treatment of the hemophilia, they take costly factors requirements are reduced. So definitely all the centers, all the district hospital in the Gujarat drastically and very comprehensively implemented the only and only regular replacement therapy in all the cases, like mild cases and moderate we are giving EHL therapy. In that also there is this upgradation, not any SHL, only weekly the patient has to come. So compliance of patient is not an issue, number one. And second, those who are having severe hemophilia and having target joint already involved before this availability of emicizumab, all are going to get the emicizumab. So our state is very successfully implement the policy, and very importantly, there is no shortage of supply of the product from the government procurement process. Only when the company is not able to provide, like in factor 9 we are right now facing small problem, but soon we will get cost. So I think my suggestion to other state also at the same time, now running the treatment of hemophilia very smoothly. Patients are very tension free. Doctors of course are very calm and cool because there is availability of drugs, the policy is there, patients are able to understand that this is the guideline when it is about.
Sure.
So other state can also get it done from your state by just getting the references from our state, this policy. So I think it is very easy. That is what I want want to convey by this
Well,
thing?
I'm not sure we can say it's very easy. It is possible to do in some states because there is a good coordination maybe between the physicians and the authorities. So only one comment. If you said it is also for mild hemophilia.
Yes.
So that may be a world first because mild hemophilia government policy to give prophylaxis is not standard even in the West. Maybe on a very selective basis. So that's interesting that such a policy exists. And obviously, as you rightly said, we have to quote examples of success from one state to other states.
That is very important. We also got something from the other states that
Yes.
we see these are the area where they are giving for all prophylaxis.
Collaboration and success. Dr. Alva.
Good afternoon, ladies and gentlemen. At the outset, thank you very much for calling me here, especially Mr. Prem who has invited me here. Thank you, sir, for being I feel hemophilia has walked a very long way. I can distinctly remember 2010 when I attended World Congress Hemophilia at Argentina. It was the first time there. There was a lady who came from US with 2 bags. I was with Suresh Anagwadi. These 2 bags to us, telling that, doctors, please take this to India. Trust me, Davangere. We sigh of relief that at least our 700 patients will be From that point, today we have come to a situation wherein we are for each and every patient. In fact, that is why we are all sitting here. It is so wonderful to see this incredible journey of hemophilia. I am Dr. College and Hospital, Kolkata. Actually, I represent a small community of hemophilia patients who are enrolled with us. You may be knowing ESIC organization, which comes under Ministry of Labor and Employment. We have 1,650 dispensaries across the country, 160 plus hospitals across the country, and 8 medical colleges presently, 4 in North and 4 in South India. Many of you may not be knowing that we serve close to 15 crore population of our country. We are in a situation wherein we are exploring the people who are hemophiliacs. Yet we need to find who are all the hemophiliacs all round out of this 15 crore population. We have detected good number of patients. We have identified good number of patients across the country, and we are trying to treat them in a very, very special way. I didn't wanted to comment separately about West Bengal because
No. I think just stay with the
call it as Kahibi Kabibi. If he has got an ESIC card, he can walk into any dispensary of ESIC, any hospital of ESIC, any medical service.
Right now on the prophylaxis part, please, you will offer like Dr. Farul said, mild, moderate, severe, everybody. Inhibitor, no inhibitor, everybody. What is the regular replacement prophylaxis?
Most of the drugs, I can say almost all drugs, including the prophylaxis drugs, what we are using today, non-factor prophylaxis drugs has been included in our RC, and we have direct access without any financial restriction.
are there actually. It's a real situation I am telling. On demand, not available. They come to our medical college. That is why sometimes our budget is utilized for those people. Even we write regular treatment, they get the treatment after 3 months. Some of the patients are sitting here actually. Yes, in Haryana is not doing good at all.
Yes, when the organization is so big, you may have spots which are not fully aligned with your policy, and you have to see how to do that. Let's move. We are running short on this round. We'll come back to you again. Yeah, we heard from Dr. Sunita this morning, the whole so again, I guess what you're saying is in Delhi, prophylaxis is not a policy. So CGHS is allowing.
Yes, CGHS is allowed. ESI in Delhi is good.
Is allowing.
So that is allowing. And per se, hospital patients
Yeah.
were there. So
Standard half-life and emicizumab is what is.
Kerala, it was on-demand treatment from 2012 to 2014 under the Karunya scheme run by the Lotteries Department. The first initiative on prophylaxis was taken at Alwa Center, and it was supported by the district panchayats, local self-government, which started for 10 children under 10 years of age. They were provided for, and it is running with the, that was the first one. And 2018, you were also present in the meeting by the additional chief secretary and the health minister. It was decided to start prophylaxis. And the policy was evolved in 2021. With, of course, the next protocol. Units per kilogram.
What Dr. Vijay Kumar is referring to Dutch protocol is that intermediate dose in the international guideline.
We were following the low dose protocol, which was not approved under the district panchayat. District panchayat started, then we started, emicizumab was approved in 2019. And we started emicizumab prophylaxis for 2 children under the district panchayat.
No. So I tell you what, we have heard about the Alwar district panchayat work a lot.
Yeah.
At the state level, what is the policy?
At the state level, the policy started in 2021, which is intermediate dose prophylaxis for all under 18.
With standard half-life.
With standard half-life. That was 1 year now. For those above 25 years. Above 18 years.
So how is this for anyway?
Above 18 years.
So how is this for anyway? We had a wonderful right now.
For the first 50 exposures. First,
Yeah.
as per the WFH recommendation at that time.
I know, but Kerala is implementing that.
Yeah.
Interesting. Which product? Because
Immunate.
Immunate.
Yeah.
Okay, fine. So here, first 50 exposures immunate. That's a very interesting decision. One can debate everything, but very interesting decision. At
After
the
that
state,
recombinant.
amazing decision actually. Very interesting decision to learn from. And no emicizumab for the moment.
That was the now emicizumab was started 1 year back, sir. Then the whole thing went off. Factor prophylaxis is no more there. Factor prophylaxis is gone.
And what do you call low dose?
Which one? That is 3 milligram per kilogram.
Once a month.
Once a month.
Okay. Change from all that. So no pumps.
No factor prophylaxis. No. Still.
One policy. Delhi, no prophylaxis. So therefore,
for the reimbursable patients, so they are let's say
extended half-life, those who are
Some
getting,
of the patients are there.
is it because lack of availability?
Presently, we are with MSM and we are extensively using the Excel.
Which one MSM?
Yeah.
No, so
In moderate cases, we are allowed to use EHL. The guideline of WFH, we are following all the protocols.
However, is giving emicizumab to patients of inhibitors who have frequent bleeders. I will call it intrapid prophylaxis because so long as the drug is available, they are getting. Once drug is not available, they get interruption actually. Then we have to restart again drug after 2 months, 3 months. Part is that all the 5 products are available. So on-demand therapy, there is no problem. FIBA, Novo 7, EHL. We are the first in this area who started EHL actually. Factory as well as 9 from the last year onwards.
So the moment you give emicizumab to inhibitor, it amounts to prophylaxis, except that it may not be available all the time. That's what I'm saying.
So we are having EHL, SHL, and that bypassing agent, but imosizumab is not yet in real trust.
How do you decide on prophylaxis? Who to give what between SHL and EHL?
We try to give SHL, but some of the patients, EHL, but some of the patients who are not coming to medical college because SHL is up to medical college. Extended half-life is up to medical college, and district hospital it will be only SHL.
Okay, interesting. That's again a new kind of policy. EHL only in the medical college and SHL.
Basically, our medical sales corporation has RC of all the things, right? So we have 112 are on non-factor therapy, and 45 are on third generation or fourth generation. So about how we decide with SHL and EHL. Having the longer half-life and lesser of injections, and the far-flung, because ours is a tough geographical terrain. Far away people, because we have only one center at Kashmir. We don't have a district and sub-district levels. We are also adopting home therapy. Vials by permanent marker 4 by 4, right? Then when he comes with the those with marker vials, then we will issue the second one. Available corporation, warehouse, drug warehouse, they are not releasing.
No, this. For whom? No. So, but ESI, he says no. So you better be careful. He'll stop you. But home therapy. Now that's different altogether. Now, which category of officially reimbursed people, supported people, can you officially do home therapy? He is doing with government knowledge.
Just a minute, sir. Because he is a privilege of having a mountains area and something like a, that is a different thing, and our hospital are accessible, it is on the SG highway.
Much as all of us on this stage today are doctors, do you ever want to see a doctor as a patient? To see a doctor as a patient? No, you never want want to see a doctor as a patient if you can help it. So I think, going towards home therapy will be our goal finally. So we are almost out of time. Anybody else wants to ask the panel any questions? I want to know whether the experience in Surat is the same as Ahmedabad. Sometimes in one state there can be variations. So what is Dr. Vijesha? There's a mic there. No? Can somebody put on that mic, please? Implementation in Brazil for a long time, everything was available in Brasilia. Oh yeah. Very good. So
Surat also is following the same. This also by prophylaxis for all individuals.
anybody else, any comments, questions for the panel? You have a question? Yeah, please. This mic may be working. I don't know. They also must hear you. Experience because of a reaction? But that is a very exceptional situation. Because if you take one dose and go to the hospital. That's a different issue altogether. But there is no escape because any chronic illness, you cannot expect the family to go to the hospital. So, that you have to go to a hospital on a regular basis given it as to how and when we will implement, and his idea of putting some marks so that they can still sell it, but, but please go ahead. One mic, or if you come to the front a little bit, please. In Gujarat.
And additionally, NHM grant is also there as per the hospital. It is up to 4 crore.
So total comes to per year roughly, Dr. 40?
I think so.
Okay.
One hospital. But see, they allot this grant and all these things according to the number of patient in your hemophilia daycare center. All of the policy makers and the government of Gujarat and all the doctors involved in hemophilia is some state it has been found like in previous some meetings that underuse
Short comments?
Yes, sir. Sir,
Go ahead.
I've got an appeal to HFI. All the medical colleges in our country must liaison with the government as well as with the NMC to ensure that for NMC, for inspection, they must have a comprehensive hemophilia care center wherein definitely we can reach people who are unreached.
In the care of the hemophilic is that every time, every citizen or metabolic syndrome is all those who are sitting here, those who are online, please take care of your weight, maintain your BMI, regularly check your metabolic syndrome is worsening. So otherwise the factor requirement are increasing and fund constraint may come. This is what I.
Sir, I have just one reservation. The comments given by fellow colleague regarding the every district or every medical college there should be a comprehensive hemophilia. The way the government is opening the medical college at every district level, they are short of a regular faculty, trained faculty in other department.
I know.
Talk about the specialist sector. This is not possible at practically at all.
I think it was an aspirational request. But anyway, I think I think we are out of time. So I think this has been a very instructive and informative discussion for me. I hope you also learned something. Thank you all so much. Wonderful work and wonderful perspective. Also some thoughts for HFI to follow up on, because I think we must always learn from those who are doing better. Here there is a whole spectrum of examples. Try to use that for advocacy also. One state, managed by one particular political affiliation can do so well, at least the same political affiliation in the other states must do the same, and then others must try to copy. What is the problem? Let us see how it goes, right? Thank you all so much. I'll close it and hand it back to our organizers. Thank you all so much.
I would like to thank all the panelists and a special thanks to Dr. Alok Srivastav for this amazing panel discussion. I would like to invite Ms. Indra Nair, Women's Group Head of Hemophilia Federation of India, to felicitate Dr. Parul Bhatt. First the group photo and then we will get into it. You all. I would like to request Indra ma'am to felicitate Dr. Parul Bhatt. I would also like to ask Indra ma'am to felicitate Dr. Sudhir Atri. I would like to invite Chittaranjan Das, RCC East, Hemophilia Federation of India, to felicitate Dr. Nandakishore Alva. I would also like for Chittaranjan to felicitate Dr. Shalini Panwar. I would like to ask Chittaranjan to felicitate Dr. Vikas Patela. I would like to invite Dharam Singh, Hemophilia Federation of India, to felicitate Dr. Bilal Ahmed. I also request Dharam to felicitate Dr. Mukul Agarwal. I would like to invite Mr. Santosh Jaiswal, EC member, Hemophilia Federation of India, to felicitate Dr. Vijay Kumar. would like to thank all the panelists for this amazing panel. Up next, we have a very special request from the women's group of Hemophilia Federation of India, who have made a video, a very short video that we would like to show to everyone. Special thanks to the women's group of Hemophilia Federation of India for that wonderful video. Now I would like to call on stage Ms. Saranga Pawar, CEO, Hemophilia Federation of India, to deliver the vote of thanks.
तो आदरणीय अतिथिगण, डॉक्टरगण, सभी स्वास्थ्य कर्मी, हमारे हीमोफीलिया वॉलंटियर्स, हीमोफीलिया फेडरेशन ईसी कमेटी मेंबर्स, एचएफआई हेडक्वार्टर टीम मेंबर्स और इस प्रोग्राम से जुड़े सभी लोगों को मेरा नमस्कार। मैं आपका इस इनिशिएटिव ऑन हीमोफीलिया केयर के 9th कंटिन्यूसली 9वें साल में संपन्न होने पर बहुत धन्यवाद करती हूँ आप सभी लोगों का, स्पेशली स्टेट नोडल ऑफिसर्स का, हमारे स्पीकर्स का, जिसकी वजह से हमें इतनी नई चीज़ें लर्न करने को मिली, क्रॉस लर्निंग हुई हमारी। और मैं उनको धन्यवाद करती हूँ कि उन्होंने अपने अनुभव, ज्ञान और विचार साझा किए सभी के साथ, एक दूसरे के साथ, इस मंच को बढ़ाया। तो मैं माननीय मुख्य अतिथि एस गोविंद राज जी, जो कमिश्नर डिसेबिलिटी थे, उनका धन्यवाद करती हूँ हमारे प्रोग्राम में गरिमा प्रदान करने के लिए। और वर्ष का कार्यक्रम महिलाओं को समर्पित था और महिला समूह की सभी सक्रिय सहभागिता ने इस आयोजन को और भी प्रभावशाली बना दिया। अभी रिसेंटली हमने वीडियो भी देखी और वुमेन ग्रुप लीडर इंदिरा मैम का ये हमारी पहल जो काफ़ी वक्त से चलती आ रही है, हीमोफीलिया के प्रति जागरूकता बढ़ाने और समन्वित देखभाल को प्रोत्साहित करने, जिसको हम इंटीग्रेटेड केयर, कॉम्प्रिहेंसिव केयर कह रहे थे, उसमें और नीति निर्माण में ठोस दिशा देने का एक महत्वपूर्ण प्रयास रही है। तो आप सब लोगों की वजह से हमारे जितने डॉक्टर्स राज्य से आए हैं, एचटीसी से आए हैं, मिशन नोडल डॉक्टर्स आए हैं और वॉलंटियर्स और टेक्निकल टीम्स, पूरे हमारी एचएफआई की टीम दिन रात 10-15 दिन से काम कर रहे हैं। अल्फा ड्रग्स एंड क्रिटिकल या उन लोगों की वजह से हम यहाँ पर एकत्रित हो उन लोगों की वजह से हम यहाँ पर एकत्रित हो उनको हमारी सोसाइटी को स्पॉन्सर करने के लिए थैंक यू फॉर दिस प्रोग्राम। सो डॉक्टर हितेश, प्लीज कम ऑन द स्टेज। प्लीज कम ऑन द स्टेज विद योर टीम। बिग हैंड, फ्यूचर में भी ऐसे स्पॉन्सर करते रहे। या नोवो नॉर्डिक्स, मिस्टर सुनीत शर्मा लीड कर रहे हैं। यूथ ग्रुप चेयरमैन मिस्टर संतोष जी विल फेलिसिटेट हिम। या टकेडा टीम, Takeda team sponsors. Anybody from Pfizer team? On behalf of Takeda, नहीं है यहाँ पे, अच्छा आ रहे हैं.